in more than 40 countries, I have observed more commonalities than differences concerning implementing mental health reforms. We, when I say we, I can say I, but, well, I and many others may identify 6 barriers which in majority of countries, no matter if they are low-income countries, middle-income countries, high-income countries, still those barriers prevent the development of innovative, evidence-based and human rights-driven reforms. Those 6 barriers are the persistence of psychiatric institutions, 1. 2, the too little investment in creating community mental health teams or community mental health centers, relying as well on beds in general hospitals. Number 3, primary health care role has never been enough valued and supervised and supported. Number 4, persons with long-term disabilities still are in institutions and still are exposed to systematic human rights violation. I insist, systematic human rights violations. Number 5, lack of investment in prevention and in minimizing effects of social determinants. And number 6, human rights literacy and mental health promotion dramatically insufficient, which imply the lack of empowerment of users. Still, users are not enough empowered, or not at all empowered, to be frank. All these barriers should be addressed all together, and they should be seen as the key entry point for change. However, let's be honest, things are much more complex than that, and it would be rather naive thinking that health authorities of a given countries may address the 6 barriers I mentioned one after the other in an automatic and bureaucratic way. A vision is needed, and some overarching principles should be carefully considered as the frame of any specific action. 3 principles. The first principle has to do with the urgent need of reframing mental health as a dimension composed by a continuum of conditions in which the same individual could be in different phases of her or his life. Consequently, investments, resources should be also distributed across this horizontal line and not concentrated just in the segment disorder treatment hospital. The second overarching principle may look very trivial, I apologize, but it is systematically ignored. Mental health reform could be more than a piece of paper only if they are run both top-down and bottom-up. It seems very trivial. Top-down means that policymakers will never be able to implement a reform without the strong commitment of professionals and local leaders working in the field. Bottom-up means that the most generous and committed group of professionals working in the field will never be able to implement a national reform without a clear political willingness and commitment from their health authorities. This looks quite obvious, but the world, I'm afraid, is plenty of thinkers acting without doers, and plenty of doers acting without thinking. The third principle has to do with the need of a systematic involvement of users and families in conceiving reforms, in planning, in implementing, in contributing to training of all stakeholders. Let me say, in conclusion, that reorienting, reorganizing mental health policy, plans, and services is somehow even more important than producing a policy document. Policies often stay in a drawer, while radically reoriented services treat a positive dynamic in the reality. Well, few words of introduction. I don't know whether they were useful or not, but just to give the frame to our discussion of today. We have 8 thematic sessions, so we have 8 speakers. I am afraid to say I will be tough, strict, unpleasant. You have 5 minutes, and you will have only 5 minutes to present. There are 4 speakers for the first 4 thematic sessions, then they will leave, and the second group of other 4 speakers of the other 4 thematic sessions. May I ask you, when you start, to say your name and your country, and then you have 8 minutes with or without slides. The first speaker is Dr. Roberto Mezzina, talking from the topic community mental health. Dr. Mezzina, you have the floor.
Come si va? Così? Questo qua, questo okay. Thank you very much. This is the final recommendations. That's not the right one. That's not the right one. No, no. I sent it last night. Sorry. I have to leave the floor, but that's not the right file. It's not the right file.
Because there is a problem with the slides. Okay. Are you fine? Are you okay? Well, let's move to the second speaker, Carmen Valle Trabadello. You have the floor, madam, on the topic of emergency preparedness. You have the floor.
Thank you so much, colleagues, excellencies. Thank you so much for your time this morning. Our session, my name is Carmen Valle, and I'm the co-chair of the Interagency Standing Committee Reference Group for Mental Health and Psychosocial Support, together with the Ministry of Foreign Affairs of the Netherlands. We organized the session on emergency preparedness. The session key takeaways are quite simple and straightforward. Preparedness for mental health, psychosocial needs in emergencies is crucial for all countries all over the world. There's no country, as we learned unfortunately with COVID-19, that is not going to be exposed to emergencies, so we need to make sure that the right preparedness is in place. Emergencies are going to come with a wide range of stressors and an impact on the mental health and well-being of the population. And these are going to be needs that are going to be diverse from the regular work that we do as mental health professionals. So we really need to make sure that we use tailored and specialized response. Being prepared, the good news is that being prepared for emergencies, MHPSS, mental health and psychosocial support, means better recovery and better rebuilding. So it's a really clever choice to do so we can support our populations in recovering faster. What does being prepared means? It means having a strong health, but also social, education, and other systems that are also integrating these elements of MHPSS preparedness. The good news is that there are a vast amount of tools, knowledge, expertise, and evidence that is coming from the emergency response field, that is coming from countries themselves who have been in the past years developing this knowledge. We heard during the session several examples from countries that have been exposed to protracted crisis, to compounding crisis, who have been showing how building within that response already the recovery elements and already the how are we going to be prepared for the next one. So those elements are there, that expertise is there, and actually we will make a call for the use of this expertise, because the opposite can actually do harm. If we don't use a specific expertise on emergency response, we might worsen the conditions of those who are impacted by emergencies. During the session, a few key points were made by those who have been responding in countries, by the use of tools that can prepare the countries to be ready. And the core messages that came out of that was the use of MHPSS inclusive emergency preparedness that brings the expertise of all sectors in, and across the different levels of the response. We would like to make a special call for the Ministers of Health as key actors in this preparedness, to have emergency response plans and emergency preparedness plans that integrate very strongly MHPSS as is being developed by the experts that I was mentioning. We believe in cooperation, we believe in co-creation, we believe in coming together so we can learn more from your ministries on how to do our work as MHPSS responders, but we can also show our expertise and an evidence to be integrated from today. The key message was, do not wait for an emergency to happen. Don't wait until the emergency is already affecting the population and having that impact on the mental health and well-being, but rather start thinking now and start integrating now all of the tools that we know in all of the sectors that are relevant, as I was saying, not only health, but also education, social welfare, and so on. And do this so the recovery of these emergencies will be faster, will be better, and we allowed us, as one of our colleagues was expressing, not only to use the BBB, Building Back Better principle, but maybe also building better before and trying to be prepared for the next emergency and the compounded ones. That's it from my side. Thank you so much.
Thank you very much to Carmen Valle Trabadelo. Muchísimas gracias. Te respeto el tiempo. I don't see Dr. Mezzina, so he's lost somehow. And we are moving to the third group, which is children, youth, and adolescents. This group had two rapporteurs, two coordinators, Zainab Ijazi and Chiara Servili, and they decided to give the floor to one of the participants of the group, who is Miss Sharon Sitania from Indonesia, and she is a youth advocate. Sitania, you have the floor.
Thank you. Good morning, ladies and gentlemen. My name is Sharon. I'm from Indonesia, and I'm a youth advocate. I'm very happy to have taken part and contributed to this mental health summit. And today I am representing the Child, Adolescent, and Young People Working Group and want to share with you tangible actions and recommendations that we put forth to the member states today. And in our efforts to advocate for their role and accountabilities to promote skills, rights, and care for children's mental health. Here are our top three recommendations. First, we need leadership, both from young advocates as well as governments across sectors, and coordinated efforts to improve opportunities for young people and families to access mental health promotion and care. Meeting children where they are in their communities, primarily through their homes and schools and through primary health care. Second, we need sustained investment to build a competent workforce across sectors that focuses on child and adolescent mental health, supporting the skill on young people, their parents, and the community to enable an improved protective environment and efficient delivery on mental health and psychosocial interventions through collaborative networks. And at the heart of this is eliminating stigma and discrimination at levels of the community and prioritizing the mental health and well-being of caregivers themselves. And finally, let us not forget the critical need to fill the data gap and improve country capacity to monitor quality and impact of mental health services. With an emphasis on the monitoring of quality and human rights standards of care that are at the center of our child rights and strength-based approach to protection of young people's mental health and well-being. We urge you to keep young people and their caregivers on your mind and at the table in your conversations and effort around mental health system and services in your country. Thank you.
Thank you very much, Mr. Tania, for your very punchy statement. Dr. Medina is back, so...
Slight return.
All right. So you have your 5 minutes.
Thank you very much. Can I have the presentation, please? Hello? Okay. Thank you very much. So these are 9 recommendations regarding community mental health. I will just read those. Move away from institutions, deinstitutionalization. It's first and foremost needed to move away from institutions that are based on coercion and involuntary placement by letting go controlling practices that exclude people with psychiatric and psychosocial disabilities from their communities. Decentralization involves a radical paradigm shift to more humane, person-centered care that must be achieved at all latitudes and at all levels of economic and social development. Second, implement effective policies and practices to overcome old hospital-centric systems. It means national and local planning for gradual downsizing of large psychiatric hospitals, shifting the investment of resources toward new community services, including personal planning budgets, improving the human rights and social connection of previous inpatients, planning effective discharge and community reintegration, ensuring housing, income and occupation, and due support on part of community services. Shift to a resourceful community mental health service. Community-based systems must function as a full alternative to hospitals, so they need to guarantee a well-resourced, as much as possible, 24 hours comprehensive response outside hospitals and in people's living environments. This must be established and strengthened alongside the closure of institutions and include lived experience expertise into community care practices and guidance for clients towards recovery as peer support workers during care. 4 is apply fundamental values underpinning community mental health. Mental health in the community must be based on a whole life approach and contrast mere reductionist biomedical treatments. This requires widening the vision toward a whole system, whole community approach to recovery involving citizens and communities. 5th, enable the functions of community mental health services. Comprehensive services, community mental health centers and teams must act as one-stop shop hubs to coordinate the delivery of all range of services at community level to avoid risk of fragmentation. These services should be organized and equipped with instrumental, economic and human resources in order to encompass functions of prevention, crisis response, basic mental health care and rehabilitation with clear recovery focus. A clear mandate should be that of offering effective alternatives to coercion and involuntary treatments, institutional placement and confinement. 6, integrate mental health care into social and welfare systems, following a public health vision, finally responding to whole life needs and social determinants at the individual and collective levels. Community-based services ought to be mainstreamed into healthcare organizations to achieve the highest possible level of health and well-being, integrated within social and welfare policies, adopting multi-sector coordination to cover housing, work, and social inclusion, partnered by effective informal services run by NGOs. And finally, this is number 7, ensure proximity of care and community engagement. Services have to be offered as close as possible to people's homes and in neighborhoods known to the person as vital part of community life. Community engagement and development are important components of this shift to a community and person-centered paradigm of care. Displacement to remote services, basically admission to psychiatric hospital, has to be abandoned also in low-income countries. 8, promote co-production by lived experience and empowerment. Such services need to be planned, delivered, and evaluated in co-production with stakeholders, starting from people with lived experience and their carers. Information, consultation, and decision-making must be conceived as mandatory steps at inception of projects for involving and empowering community services organizations. Peer expertise and work must be valued at the same level as mental health professionals. Address stigma and community attitude toward mental health. This is the last one. Stigma and discrimination must be challenged and overcome through empowerment, visibility, social representation, and presence of people with lived experience. A new culture must be based on common understanding rather than on prejudice, looking at mental health and well-being as a common concern and a right for all. Treatment and care must be enlarged to raise awareness of life circumstances and social determinants, solidarity and commonality, and to mobilize relational resources, social support and opportunities, and new life projects. I have to thank all the participants, and particularly the coordinator, Claudia Sartor, that worked with me for these recommendations, with all those who have made contributions. Thank you very much.
Thank you, Dr. Mezzina. Your presentation was quite dense and concentrated and rich. So I assume, I'm not sure, but I assume that organizer will make available the slides of those conclusive sessions. I see, yes. So these slides will be available to all of you. So we move to the fourth speaker, and the group was capacity building and skills, and Franck Bellivier is the speaker. Sir, you have the floor.
Thank you, Mr. Chairman, ladies and gentlemen. So, first of all, I would like to thank my co-chair, Dan Chisholm from the WHO, and the 6 speakers we had during this capacity building and skills session, speakers from all around the world. And, well, actually, we had a very interesting session. So my name is Franck Bellivier. I'm the French Ministerial Delegate for Mental Health and Psychiatry. And so I co-chaired this session yesterday. So 3 key messages came out from this workshop. First, on workforce planning and development, and it was on this first topic strongly recommended to construct and revisit plans for workforce development and associated capacity building to ensure, first, that they are based on the expected needs of the population. Second, that they cover not only specialists, but also non-specialist caregivers, care providers. And third, that they enable and empower different occupational categories to carry out specific roles and function in the mental health system. And we had yesterday a very interesting example given by Rachel Merlet on health mediator in French Guiana as an illustration of these intermediate categories of new workforce. The second key message was service user in capacity building, and it was recommended to enrich and extend training and capacity building programs by first developing self-management and support tools, and second by engaging people with lived experience in pre-service and in-service training. And we had several presentations and illustration yesterday on this issue. Selection, training, and supervision of peer support actors, people with lived experience, is of key importance. And what was also stressed yesterday is that training of mental health workforce, the training of mental health teams to incorporate people with lived experience for this peer helping activities is also a major stake. The third key message yesterday was on digital and e-based training. Harness and exploit. It was recommended to harness and exploit digital e-learning tools and technologies for the expedited transfer and scale-up of knowledge, skills, and competencies needed to deliver a comprehensive network of person-centered, right-based, and quality care in the community. And during the yesterday's session, e-training of the Quality Right program in Ghana, for example, opened very interesting perspective of large-scale training, supervision, and intervention using digital approaches. These are the three key messages I wanted to deliver to summarize this workshop we had yesterday, and I thank you for your attention.
Thank you, Dr. Belivier. Thank you very much. Merci pour votre intervention. Now I'm asking Professor Kendall, Sofia Ribeiro, Gianfranco Costanzo, and James Woolard to take and to come to the front table. Maybe, magari cambiamo I cavalieri, se possibile. Sì. Perfetto. Grazie. Woolard. There. Costanzo.
We're doing it.
Professor Kendall here.
Yeah. Professor started joining.
Yes.
What do you want to sit here?
Right.
Okay.
And Sofia Ribeiro there. There's a chair like, no, okay. Yeah, second chair. Yeah, please. That's right. So are you presenting two people?
Yeah.
Presenting?
Yeah.
You will take 5 minutes, no more?
No more.
No. That's
Probably
fantastic. Oh, that's fantastic. Wonderful. So thank you very much. So we have the other four thematic sessions, starting with Professor Tim Kendall, the National Clinical Director for Mental Health of the United Kingdom, who will present and will use the 5 minutes, sharing the time with a colleague from United Kingdom as well. Can you say your name, sir?
I'm Professor Brendan Stone. I've had a lifelong lived experience, and I still live with mental illness today.
Yes, you're welcome, sir. So you have the floor, 5 minutes. the two of you.
Okay, thank you. Okay, so we were following on from Roberto's excellent workshop on community mental health. We wanted to look at the sustainability of community mental health and what were the key ingredients. So we agreed with pretty much everything that Roberto had said. And in terms of sustainability, we could have talked about training, we could have talked about housing, we could have talked about access to supported housing, we could have talked about work and employment and social care and so on and so on and so on. So instead, we focused down on three areas, three which we thought were absolutely necessary for us to be able to sustain proper deinstitutionalized community mental health. And they were stigma, leadership, legislation and rights, and investment. And whilst they're necessary, we didn't think they were sufficient, but they are absolutely necessary. So Brendan's going to say about the first part. So, Brendan.
Yes, we had a fantastic session and we listened to Graham and Claudia speak about stigma and the recommendations, the framework laid out in the Lancet Commission. And the recommendation is that to implement and sustain community mental health, all governments must have in place a clear programme for stigma reduction and meeting the inclusivity criteria laid out in the World Health Organization Comprehensive Mental Health Action Plan. And Graham was he recommended that we take heed of the important finding that people with lived experience are critical change agents in changing community attitudes and destigmatizing mental illness.
And then on next slide.
Next slide, please. Yeah, do you want me
Oh,
to
that's it. Yeah, go on, you do.
In this session, we heard again from Roberto, Naomi from Kenya, myself, and this powerful recommendation speaks to the need to implement and sustain community mental health. All governments need to take full recognition of the leadership and capabilities of people with mental health conditions and the rights of people with mental health conditions. To achieve this, we recommend adopting a new model of mental health care which can learn from exemplary systems outlined in the World Health Organization Mental Health Report. And this focus on leadership, inclusion of people living with mental illness has been a thread that has united the diverse sessions, I think, at many of the conversations we've heard during this event.
Thank you. And the final slide. So we're really pleased and grateful that we had 4 ministers all talking about what they were proud of in terms of changes in mental health in each of their countries. And importantly, all 4 were women. And I have to say, the entire audience clapped when that was pointed out. So we're very pleased, and everyone was really quite open about what their plans were for the future. I think there was some caution about our ability to invest in the future, but I think everybody agreed that we needed to invest and we needed to ensure that mental and physical health care got the same kind of investment. So the recommendation was to implement and sustain community mental health. All governments should, subject to national contexts, aim to ensure adequate mental health care funding consistent with physical health care. Public finance for mental health should be decentralised to prioritise community services and away from tertiary level facilities. And that really was quite an important addition at the end, that this needs to be devolved down to localities. So that just leaves me a few seconds to say thank you to everyone who was involved, and to Brendan, who I think has led us with this really quite well. So thank you very much.
Thank you very much indeed. Our British colleagues were able to make a quite solid presentation, few minutes, 2 speakers. Fantastic. Fantastic. Let's move to the workforce mental health. We have Mrs. Sofia Ribeiro from the International Federation of Red Cross. Ms. Ribeiro, you have the floor.
Good morning, ladies and gentlemen. So my name is Sofia Ribeiro. I come from the International Federation of the Red Cross, and I had the pleasure to co-coordinate this session with my colleague Stavroula. And if you could move to the next slide, please. Just to remind who were the distinguished guests who were with us, and that we thank you.
The green one.
Okay, thank you very much. So we had Dr. Aisha with us from the WHO, and she took us through the recently released guidelines for mental health at work and the policy brief that were released just in the 28th of September, if I remember correctly. And she presented it as a scientific product that shows what doesn't work. So I invite all of you to take a look at that. Dr. Cristina Di Teco brought us a case example, so the example of Italy in implementing policies and activities and initiatives to address the mental health and well-being of workers, taking advantage somehow of the circumstances the pandemic created by really showing how mental health in the workplace is critical. And then Dr. Sama from Palestine, she brought us a very powerful statement from the circumstances that mental health professionals go through in the Palestine. She reminded us on how some trivial things for all of us are not trivial in some contexts. And I again invite you to then watch the recording. It was very powerful. And finally, my dear colleague Shona from the IFRC joined us to take us a bit through what has been the process in the international Red Cross, Red Crescent movement, from developing a policy on addressing mental health and psychosocial well-being to then developing a roadmap to implement it and to make it actionable, and also delving a little bit more on one of the priority action areas of that roadmap, that is on caring for staff and volunteers. But before we started, we actually had the opportunity of having with us the president of the International Federation of the Red Cross, who was here yesterday, also moderating a session in the morning. And he just reminded us of the role of volunteers, so that when we talk about workforce, we need to think also about the volunteers. For the IFRC network is more than 14 million. So it is also important to remind that they have their specific stressors, then those also need to be addressed. And finally, he also brought us some of his personal experience also on the role of managers and leaders, and how they must also lead by example, by also creating the circumstances for people to feel comfortable to be vulnerable and to create that workspace. We have 4 main takeaways to share with you today. One is that work can protect or harm mental health, and therefore it is a risk factor, but is also an opportunity. So there needs to be a multidisciplinary approach to address it, and it needs also to be multidimensional. We need to act on prevention of mental health and psychosocial well-being. We need to act on promoting and protecting it, and we need to act also on supporting it, particularly for those people who suffer from mental health conditions, ensuring that they have the right circumstances to be able to contribute to the society and in the workforce. Then binding policies are essential. They can really, really lead the way for change, but binding policies in itself is not enough. They need to involve all the relevant stakeholders to ensure buy-in, and they also need to be developed alongside frameworks that will make them actionable. Otherwise, they have the risk of just becoming papers, like Professor Saraceno mentioned. Then managers and leaders are essential in the process. They can impact on creating supportive work cultures. They are themselves important sources of support for their staff, and they are an integral part of the systems for developing supportive work cultures and initiatives. So if there's not buy-in from managers and leaders, it can be challenging. And finally, guidelines and case studies are very, very important. We should look at what's out there, for example, with the case studies that we listened in our session that were, again, so powerful and so inspiring. But we need to be reminded that context is fundamental. What will work for some will not work for others, and we need to have that flexibility. And finally, there was a bit of a call for innovative approaches to be joined, and that would be it. Thank you very much.
Thank you, Ms. Ribeiro. Thank you very much. We move to the thematic session number 7, People on the Move. And we have Dr. Gianfranco Costanzo, the director of the National Institute for Health, Migration and Poverty of Italy. Dr. Costanzo, you have the floor, 5 minutes.
I don't know if it works. Okay, it works. Yes, in yesterday's session, Guglielmo Schinina from IOM&I coordinated an excellent discussion on major issues related to the mental health of people on the move. We structured the session into the different stages of the migration journey and asked 3 key speakers to give their views on the pre-departure and return on the country of origin, on the transit and arrival. Dr. Schinina unfolded first the key terms of migration and outlined the session. Dr. Bore Tiene, psychologist from Mali, told us about the major mental health problems encountered in pre-departure related to the fear of leaving the family and community of origin first. But also about the main critical issues of return, consisting of the different, or the difficulty of accessing primary care services essentially designed for residents, or of the scarcity of trained psychologists who can care for returnees, often suffering from traumatic experiences, low self-esteem and negative thinking. Dr. Liliana Campos, a psychologist born in Mexico and immigrated to the US at the age of 10, spoke to us about the mental health issues of migrants transiting through a country. In particular, she highlighted the problems related to reaching migrants in many camps and shelters. And she then highlighted the need to consider mental health comprehensively and to prioritize opportunity for access to services, outreaching with mobile clinics and continuity of care. Finally, she recalled the need to include mental health within primary, secondary, and tertiary care. Last but not least, Dr. Dinesh Bugra, famous psychiatrist and anthropologist who moved from India to the UK, portrayed to us the major problems and limitations of migrant people finally arriving in new countries. As such, he has distinguished the mental health fates of economic migrants from those fleeing out for necessity. The level of personnel, I don't know how to proceed with the okay. Yes, the level of knowledge of healthcare system for the latter, the training level of healthcare personnel on cultural diversity and ethnopsychiatry, and the role of transcultural mediation in clinical setting and health assessment were essential to him. Again, he reminded us of the influence of geopolitical factors on migrants' social determinants of health. After the intervention, we launched a debate on the room and online, summarized the discussion key points, and proposed to the audience and speakers the adoption of 5 recommendations for policies on mental health of people on the move. First, advocate migrants' access to primary, secondary, and tertiary level of mental health care, irrespective of the legal status. Second, advocate for mainstreaming mental health care and primary health care and within emergency response. Third, make sure mental health care services are culturally diversity competent through the deployment of transcultural mediation on health issues, interpretation and translation, and training for providers. Fourth, mainstream mental health care in all social systems relevant to migrants' access and outreach to migrants, like the educational, law enforcement, religious, and social care ones. And fifth, create competencies among migrants' communities. The cross-cutting point was that the patient, the person, is at the very center of all these policies oriented to mental health care. Thank you very much.
Thank you. Thank you very much, Dr. Costanzo. Again, the recommendations of the slides will be made available to all participants. Last, thematic group, innovation and mental health. So James Bullard, National Specialty Advisor for Digital Mental Health in the United Kingdom. Take the floor. You have 5 minutes, sir.
Excellent. So I am Dr. James Bullard. I'm a consultant child and adolescent psychiatrist and the National Specialty Advisor for Digital Mental Health, and I co-chaired the Innovation in Mental Health session with my colleague Pim Kuipers from the Netherlands, and these are our overview and sort of recommendations. Hopefully my slides. Am I pressing the... Okay. So I challenge the audience to think about the mobile phone in their pocket and what opportunity that presents to us in terms of access to mental health care. What does your mobile phone tell us about your mental health? And that led us on to an interesting discussion about the rights of the individual, and that's a key theme from the summit over the last few days. And we carefully considered the rights to effective, safe digital interventions, and Pim gave us an overview of the evidence that these treatments are safe and effective. We also considered the rights of the individual to their data privacy, and that's a key concern when technology allows organizations, agencies to collect a lot of data about us in ways that we don't necessarily understand. So whilst we can overcome barriers of stigma and access with mobile phones, we need to be, and smartphone technology generally, we need to be careful. It should not be at the cost of people's privacy. So we need to work together to ensure that government departments are aligned and coordinated in their policies, that we are not providing conflicting policies to our population about how we both improve and manage their mental health whilst also putting their privacy at risk. We need to ensure through these conversations that patients, as others have said, citizens are at the center of those conversations, using the cultures and practices of the digital age, user-centered design, co-production. And again, another theme of our summit, skills. It was absolutely clear that leadership is critical, and we've heard that from other sessions as well. But in the digital space, it isn't just about the traditional models of clinical leadership. It's about the overlap between digital skills, knowledge, and experience, as well as those traditional clinical leadership competencies. So we need to make sure that we invest in those digital clinical leaders at organizational, regional, and national levels. We need to invest in those additional roles, those e-helpers, those digital navigators, those semi-professionals who can help our citizens make the best use of those safe, effective technologies. And finally, we need to take care. We need to take care about choosing what will work in our context, understanding the infrastructure that needs to support it, thinking about how, again, we work across government departments to align investment in Wi-Fi and those infrastructure, digital infrastructure that supports the use of these technologies. And finally, we came to the idea that if we could have a further meeting, a convention of those identified digital mental health leaders from around the world, we could take care and be careful about those developments and work together and share best practice of how we do this well, mindful of those rights, mindful of the skills we need to develop in our workforce. And I look forward to that meeting. I hope I'm there, and all I can ask is, who will join me? Thank you.
Thank you. Thank you very much for this innovative presentation about innovation. Thank you very much. We have a few minutes left. I'm asking to the 8 speakers if someone wants to use 30 seconds to give us a take-home sentence. Do you have something? If you want to say one sentence that you want us remember what was the core of your presentation. It's not mandatory. I mean, if you can decide to say something or not. Yeah? Mr. Ribeiro? 30 seconds, a sentence. Go on.
Can you hear me?
Yes.
Yes? Okay. Well, actually, it's just something I wanted to, but the time was over. I just wanted to say that we're talking in our panel about workforce mental health, and just to acknowledge the work of everyone that contributed to this summit. I'm sure there was stressful moments in the process, so it was just really to share a word of appreciation to the organizing committee and to everyone who participated, and thank you for the resilience throughout the process.
Thank you very much. Professor Kendall, one sentence.
Okay, my sentence is this. I think that community mental health was born in Italy, and I'm really pleased that we were able to bring the global summit here. And my final sentence is to echo, although it's not exactly the words of Franco Basaglia, is that we don't need more therapeutic communities and hospitals. What we need are communities that are therapeutic. Thank you.
Thank you, Professor Kendall.
Yeah, thank you. I think that
one sentence.
Yeah, the sentence is that the healthcare systems should be prepared and ready to understand the cultural diversity and to act consequently. So the preparation, through the preparation of healthcare personnel, but also social workers. So the orientation to different cultures is really important to understand these real needs.
Got it. Mr. Bull.
I think I'd just like to reiterate my last point, which is I think this is the beginning of a conversation, and I'm more than happy to work with colleagues around the world to support the careful use of these safe, effective digital interventions that could make a transformative difference to the world.
Thank you. Dr. Mezzina, one sentence. No, you get the microphone. Dr. Mezzina is not lucky with technology.
There's some innovation.
Right. Fantastic.
No, that's okay.
Good.
Thank you.
One sentence.
Very good. No, just echo what Tim Kendall said. So I think it's important to remind community mental health cannot be done without a vital community. So the community participation and development is a core issue that we must remind when we set up services. The community must participate, particularly with those who are the holders of services and those who are using services.
Thank you. Carmen Valle.
Carmen.
One sentence.
Thank you so much. I will just steal the words in our panel from the Deputy Minister of Health of Liberia, who very clever. If you don't prepare, if you fail to prepare, to fail. That's in terms of emergency what I would highlight. Thank you.
Thank you. Sharon Sitania.
Yeah, thank you so much. So I would just love to add that we need youth leadership, and there has to be an engagement for people, for the youth and at the school, and also for the caregivers. I think that's for me.
Thank you. Dr. Bellivier, merci pour... Voilà, vous êtes là.
So one sentence you said. So the sentence would be pre-service and in-service training, as well as the creation of new workforce categories, are priorities for the future of mental health, and digital developments are key to achieve this ambition.
Thank you very much indeed. Well, we're coming to an end. I take the privilege of being the chairman of this session to add my personal take-home message. We heard these days many people saying no health without mental health. We can't agree more. I would add no mental health without rights. Human rights, civil rights, political rights, gender rights, social rights, economic rights. This also is important for mental health, not just health and mental health, but also rights and full citizenship. Thank you very much. Session is over. Thank you, sir. Thank you. Goodman. Thank you.
Ladies and gentlemen, please welcome Mr. Giovanni Leonardi, Secretary General of the Italian Ministry of Health, and Mr. Sergio Iavicoli, Director General for Communication and International Affairs of the Italian Ministry of Health.
Honorable Ministers, Excellencies, dear delegates and guests, we've just heard about the key points and recommendations from the thematic sessions of the Global Mental Health Summit 2022. Let's now move to the interventions of the heads of delegations of participant countries and international organizations. Mental health is becoming an increasingly crucial issue. The WHO report on mental health states that globally, before the COVID-19 pandemic, around 1 in 8 people lived with a mental health condition. But this number has increased due to the COVID-19 crisis. With common efforts, we must achieve a world where everyone, everywhere, has access to mental health support by preserving human rights and dignity. As mentioned by Director General of WHO, Dr. Tedros, there is no health without mental health, and no mental health without rights, as we said just now. Before we move forward to the session, let me provide you with some housekeeping information. Each intervention is to be limited to 3 minutes. I kindly ask all heads of delegations to respect the allocated time so that everyone will have the chance to speak and we can conclude the session on time. A timer on screen will help you to monitor the duration of your speech. Initially, I will give the floor in alphabetical order to the heads of delegations that have already registered their intervention. The organizing committee will take note of those who did not register yet and wish to take the floor. They will be invited to intervene at the end of the first round. I will start contradicting myself, the floor to the distinguished delegate of the United Kingdom, who has to catch a flight soon, to be followed by the distinguished delegate of Australia. Please, United Kingdom, the floor is yours.
Thank you. Firstly, I would like to thank the organisers and all involved for what has been a thought-provoking and collaborative event. As you may know, I am new to my role as Minister, and this has been an opportunity to learn from international examples of best practice and innovative problem-solving from really passionate individuals and organisations. My comments today reflect work in England, but I know that colleagues in Scotland, Wales and Northern Ireland share our commitment to improving mental health outcomes for populations. As a consultant paediatrician myself, I've worked firsthand with children and young people, and I'm acutely aware of the difference which can be made to children's lives when their mental health is protected and strengthened, preventing them with strong foundations as they move into adulthood. While clinical interventions undoubtedly play a crucial role, our life experiences and our environments are key determinations of our mental well-being overall. Bullying, drug and alcohol misuse and unemployment are just several factors which increase someone's chance of developing a mental health condition. It's for this reason that we must make sure mental health is everybody's business and not just the business of doctors, nurses and health ministers. As Minister for Mental Health in England, my predecessors and I have worked across government to address the root causes, delivering initiatives such as mental health support teams in schools and delivery of psychological first aid training to frontline government workers. But whether you're developing policy on employment or education, criminal justice or welfare, we must be rigorously assessing how those policies are promoting and improving citizens' mental health and well-being. We need a person-centred, community-based approach at the centre of any mental health strategy, and Italy is recognised as for their leadership in community mental health. The overarching aim set out in England's NHS long-term plan is to improve community support for mental health conditions, to avoid the need for an inpatient admission wherever possible. The Community Mental Health Framework, launched in 2019, sets out our vision to transform community provision for people who live with severe mental health conditions, bringing together a range of services to wrap support around individuals' needs. At its core, the framework is promoting an approach centred around individuals, ensuring services are co-produced and co-designed with people who have lived experience and their carers and their families, and that they're accessed as close to home as is possible. Finally, the pandemic taught us the importance of prioritising mental health in how we approach emergencies at a local and a global level. We need to consider the most vulnerable members of our society, ensuring that they receive the care they need when they need it. Doing so requires an integrated approach. It calls for parity of esteem between mental and physical health. The Department of Social Care in England held the inaugural summit in 2018, and I'm really pleased that this forum continues to be an opportunity for world leaders and experts to meet to ensure that mental health remains on the global agenda.
Thank you, distinguished delegate of the United Kingdom. Thank you. I give the floor to the distinguished delegate of Australia, follow the distinguished delegate of Austria. Please, Australia, the floor is yours.
On behalf of Australia's Minister for Health and Aged Care, Mark Butler, I would like to begin by acknowledging our host country, Italy, fellow Ministers of State and the organisers of the Global Mental Health Summit for bringing together 52 delegations, including 45 countries, from across the world to advance a community-focused approach to mental health. To those with a lived and living experience of mental ill health and psychosocial disability joining us here today, I reaffirm Australia's strong commitment to embed lived and living experience into leadership and decision making. It has been a privilege to represent the Australian Government at this summit, and in doing so I acknowledge our First Nations people, the stark disparity in mental health outcomes, and the Albanese Government's commitment to the Uluru Statement from the Heart to establish a First Nations voice to Parliament enshrined in our Constitution. As part of an incoming government, it has been incredibly valuable to join this summit, to meet with leaders from across the world, including many bilaterals, to learn from our shared experience and demonstrate Australia's strong commitment to international cooperation in global mental health. As your Minister Speranza said, there are now more than 1 billion people living with mental ill health, and we know in Australia the prevalence is rising. 2 in 5 Australians experience a mental health disorder during their lifetime, with young women and girls particularly impacted in what is being described as a shadow pandemic. Australians have experienced cumulative trauma through natural disasters, drought, the Black Summer bushfires and large-scale flooding. The impacts of climate change has had a profound impact on mental health and well-being, and that's why Australia is committed to embedding mental health responses into our national emergency management and taking real action on climate change. Our government is determined to take a whole-of-government, community-led approach to mental health and well-being, which strongly aligns with the aspirations and recommendations of this global international forum, with firmly underpinned by the social determinants of mental health and well-being. As has been said repeatedly at this fora, there is no health without mental health, or mental health without human rights. I strongly affirm Australia's commitment to these principles and to adopting them and implementing them across our country. Our approach will be evidence-based, and we are determined to embed lived and living experience in leadership and decision-making across our country. In conclusion, I reaffirm Australia's strong commitment to work cooperatively globally, because only by working together, genuinely and in a spirit of goodwill, will we achieve the change that we are all determined to realise and that people and communities across the world deserve. Thank you and congratulations.
Thank you, distinguished delegate of Australia. Now I give the floor to the distinguished delegate of Austria, which is from remote, followed by the distinguished delegate of Belgium. Please, Austria, the floor is yours.
Across the world. I'm honored to speak to you as the head of the Austrian delegation. Unfortunately, the Austrian Federal Minister of Social Affairs, Health, Care and Consumer Protection, Johannes Rauch, cannot attend the summit. He sends his best regards. It's my privilege to inform you about current Austrian activities related to key topics of the summit. I will focus on 7 topics: involvement of people with lived experience, stigma, suicide prevention, migration, the COVID-19 pandemic, children and young people, community health. Involvement of people with lived experience is called for in international and national strategy papers. Participation improves the quality of health system and promotes user and needs-oriented services. In 2017, the Ministry of Health established a networking platform for experts by own experience to strengthen this interest group by, for instance, defining common concerns, to enable equal participation in committees, as well as to encourage exchange and discussion within the mental health user community. A major outcome has been the foundation of a nationwide umbrella organization for experts by own experience. Stigma is still significant in the context of mental health illness. The Ministry of Health founded the competence group Destigmatization in 2018, which brings together representatives from different sectors, institutions and backgrounds. It bundles interdisciplinary and multi-perspective expertise on stigma and aims to fight stigma in a broad, impact-oriented and coordinated way. Exchange takes place, recommendations are elaborated and actions taken. The Austrian Suicide Prevention Programme, SUPRA, was recently chosen as European best practice example. Currently, 17 European countries are implementing selected components of SUPRA via the joint action implementing. SUPRA combines the development of a structured strategic concept with a simultaneous implementation of quick wins. Achievements of the program include annual monitoring, a web portal, a media prize, special programs for risk groups, post-vention guidelines, and gatekeeper trainings. The national program has also been a boost for regional programs. As a consequence of the migrant crisis in 2015, a national platform for psychosocial health of people with migration background was created. This strives to provide support for refugees and migrants by bringing together all institutions and actors in the field. It promotes cooperation and collaboration among these. Synergies are used and services coordinated in an efficient and effective way. Related to the COVID-19 pandemic, two key achievements have been the inclusion of psychosocial, i.e. mental health, in key national documents and plans, and the installation of a mental health monitoring to collect and monitor data on the psychosocial stresses of the population as a basis for taking timely decisions and measures. The vulnerability of children and adolescents has recently become even more visible. To strengthen the mental health of this population group, the Ministry of Health has initiated 2 support programs of in total more than 20 million euros to promote easy access to psychologists and psychotherapists, as well as strengthening crisis interventions of non-profit organizations. Developments towards the expansion of community mental health in Austria have unfortunately partially slowed due to the pandemic. Major current activities involve the nationwide installation of primary care centers, the expansion of crisis intervention services, and the piloting of models of home treatment in several Austrian regions. Thank you very much for your attention, and please get in touch with me and my colleague Konstantin Zieger in case you have any questions or are interested in exchange. Thank you very much.
Thank you, distinguished delegate of the Austria. Now the floor to the distinguished delegate of Belgium, followed by the distinguished delegate of Colombia. Please, Belgium, the floor is yours.
Thank you. Dear and estimate audience, it's a real pleasure to be welcome in Italy for this global summit, and many thanks to the organizers. In Belgium, we teach to future mental health professionals the story of the deinstitutionalization of mental health care in Italy and of Franco Basaglia. This story illustrates to future mental health professionals that we should not be afraid to question our care practices and to implement important reforms for a better mental health system. Belgium has also a long history of reforms toward deinstitutionalization and community-based mental health system, with the recovery of people with mental health needs as the key objective. The recent societal challenges we faced have prompted us to implement 2 major mental health actions in recent months. First, we have increased the capacity of the first line of psychological care so that people with mental health needs in Belgium find a rapid response within the community. The importance and relevance of this action has been reinforced by the COVID-19 pandemic, but also by the climate, energy, and economic crisis we are facing, with an increase in mental health needs in the population. Second, we have strengthened our One Health approach, in which we consider health and mental health in all dimensions of life in society, including policies related to employment, housing, culture, and others. Indeed, the current challenges in our societies also require to strengthen the place of social determinants within mental health, and this action is illustrated, for example, in Belgium by the implementation of an employment support program specific to people with severe mental health condition, inspired by the evidence-based individual placement and support model. We know that period of crisis can reinforce the social and economic exclusion of the most vulnerable group, including people suffering from mental health problems. Social exclusion being both an important cause and consequence of poor mental health, we must strengthen our initiative to support the social inclusion and destigmatization of people with mental health problems. Another lesson from recent crisis is to have a better crisis response preparedness of our health and mental health system to provide rapid response to the needs of the population. Our ability to anticipate the negative consequences of this crisis is essential, and to this end, we are working to strengthen action to prevent mental health problems with a particular attention to children and adolescents. Finally, international collaboration is essential to meet the new challenges of our society, And some of you may know that Belgium is a small but to some extent complex country with a federal state overlapping with 3 regions and 3 linguistic communities. So we have some experience bringing together multiple stakeholders around the table to work towards common goals. And we therefore wish to emphasize our intention to collaborate and exchange expertise and best practices. Thank you, grazie mille.
Thank you, distinguished delegate of Belgium. Now the floor to distinguished delegate of Colombia, followed by the distinguished delegate of France. Please, Colombia, the floor is yours.
Good morning, ladies and gentlemen. Thank you very much for inviting us to participate in this very important summit. I'd like to start emphasizing how important is this World Mental Health Summit, especially for giving such a relevant place to mental health into the community and focusing on people and their rights. Colombia is a multicultural and pluriethnic country with great contrast and territorial difference in urban and rural areas. And also, we have lived into armed conflict for decades, which has produced big inequalities, violence, mental health disorders, and an urgent need for transformation. According to the 2015 National Mental Health Survey, about 4.5% of the population has shown some mental disorders in the last year, mainly depression and anxiety. This situation has moved the country to the construction of a national mental health policy. The policy established mental health promotion, prevention, and care services as a key element of the primary health care provision. Otherwise, the COVID-19 pandemic means a great challenge to our health system, which leads to innovation and the search for strategies to improve access to health services. However, a decrease in the population served by 30% in health services between 2019 and 2020, with a partial recovery by 2021, has been identified. In addition, the ministry conducted a study during the pandemic that showed a risk in mental health, depression, and anxiety 3 times higher than the recorded in the National Mental Health Survey of 2015. In response to this challenge, the current government proposed the implementation of a preventive and a predictive health model where mental health is a cross-cutting component, looking forward to address the psychosocial effects of social and political violence and the change of the paradigm to address drug consumption problem from a human right and a public health perspective. We hope that this summit will strengthen the work between countries and allow us to share lessons learned to improve the response in mental health from a community perspective, recognizing people as subjects of rights and agents of change. Thank you very much.
Thank you, distinguished delegate of Colombia. Now I give the floor to distinguished delegate of France, followed by the distinguished delegate of Ghana. Please, France, the floor is yours.
Dear ministers, ladies and gentlemen, on behalf of François Braun, the French Ministry of Health, I would like first to thank our Italian colleagues and the organizing committee. This 4th edition of the Global Mental Health comes at a very right time for at least 2 reasons. Financial investment in mental health remain a priority, and international mobilization is growing and is likely to help and accelerate national reforms. The Rome meeting is another milestone to maintain mental health as a priority in the political agendas. Mental health is quite high in the French political priorities. The COVID-19 crisis has clearly accelerated the course of our mental health reforms. As an illustration, President Macron called a national conference on mental health in September last year to make a state of play and draw perspective for the future. With regard to concrete actions, several major priorities came out from the previous international meetings. Make mental health a global health priority, promote right-based actions as a lever to change practices, facilitate multi-sectorial approaches with interministerial cooperations, and foster international perspective and exchanges on best practices. The Rome meeting has complemented and deepened important topics to reach these objectives. Calls for action to improve access and quality of mental health services are currently spreading. This is why France clearly supports international initiative and why we are very committed to participate to different initiatives that recently emerged. The WHO Pan-European Coalition for Mental Health, the continuation of the Global Mental Health Summit, the participation to the Implemental Joint Action to promote group practices across borders, and more generally, cooperation between countries. We also target the 2023 Rugby World Cup and the 2024 Olympic Games and Paralympic Games in France as clear opportunities for communication and destigmatization activities on mental health. As presented in Paris last year, there are strong links and potential common objectives between sports and mental health. I would like to finish with priority messages. International mobilization for mental health is growing fantastically, but is at stake now is to keep this momentum for the coming years. Second, there is a deep movement. Patients and families, people with lived experience in general, are more and more active and their voice are more and more heard, supported by evidence-based data on empowerment and self-determination. Globally, we have important mental health networks around the world. Still, we definitely need to strengthen the links between all these actors and national policymakers to accelerate concrete action. For all these objectives, France will maintain its ambition and commitments and its will for international cooperation. Thank you for your attention, and I look forward to seeing you soon.
Thank you, distinguished delegate of France. Now give the floor to the distinguished delegate of Ghana, followed by the distinguished delegate of Indonesia. Please, Ghana, the floor is yours.
Thank you, Mr. Moderator. I also want to join my colleagues to say thank you for these organizers of this occasion. We are proud of the organizers. Ghana's vision for mental health is to have a mentally healthy population. To achieve this, Ghana has developed a mental health policy to give direction on improving its mental health situation. The policy is based on 5 broad objectives as follows: integrate and expand access to quality mental health services, including substance-related disorders, focusing on community-level services, identifying risks for and protective factors against developing and managing mental illnesses and support. Top 2, to ensure sustainable financing for mental health services delivery and finance risk protection for people with mental health conditions. 3, improve efficiency in governance and management of mental health services, focusing on human resources, research, and information, communication, and technology. 4, build partnership with sectors and harness the resources for mental health services. 5, reduce stigma and discrimination against persons with mental health conditions by promoting their human rights. There have been various health sectors interventions to achieve these objectives and improve mental health and social services in the country, namely service delivery, train all non-mental health professionals to help integrate mental health care into the primary health care system, scale up mental health gap action program training. 2, improve mental health services by ensuring quality mental health care using a human rights approach, well-health organization quality right initiative adopted. Train traditional and faith-based healers to identify and refer persons with mental health who visit their centers. human resource capability. Train mental health professionals such as psychiatrists, clinical psychiatric officers, clinical psychologists, psychiatric nurses, social workers, and occupational therapists. Ensure psychiatric nurses are all trained community mental health officers and community health officers to provide basic mental health care within communities. Finance, establish suitable means for financing mental health services, e.g., through the establishment of mental health levy, including mental health services and the minimum benefit package of the National Health Insurance. Governance and partnership, establish mental health review tribunals, visiting communities and district sub-committees for improved mental health services. Integrate mental health into existing inter-sectorial coordinating mechanisms at the district, regional, and national levels. Integrate mental health indicators into existing peer review mechanisms of the Ministry of Health and partners. Health technology and infrastructure. Build 2 long-stay facilities in the middle and northern belts of the country to provide specialist mental health services. Plans are far advanced by government. Establish a revolving fund for the sustainable supply of psychotropic medicines. Scale up the telepsychiatric to extend specialist support services. Human rights. Continue the WHO QR initiative to build capacity and change attitudes among stakeholders to promote human rights and recovery in mental health and social services.
Please, may we go to the conclusion, please.
In conclusion, health information systems integrate mental health indicators and data setting into our district health information management system to encourage mental health reporting. Thank you very much.
Thank you. Thank you, distinguished delegate of Ghana. Now the floor to the distinguished delegate of Indonesia, followed by the distinguished delegate of Canada. Please, Indonesia, the floor is yours.
Okay. Chair, distinguished guests, ladies and gentlemen. The establishment of the Directorate of Mental Health in the Ministry of Health of Indonesia in 1958 marks Indonesia's attention on mental health program. Over the period of time, the program moved around different Directorate General, from health service to disease control. Just this year, it is moved to the Directorate General of Public Health, an important move following our health system transformation agenda post-COVID-19 pandemic. The health system transformation agenda consists of 6 pillars, namely the transformation of primary health care, secondary care, health system resilience, health financing, human resource in health, and health technology. Within the primary healthcare transformation agenda, which emphasize stronger promotion and prevention, our mental health program is transitioning from facility-based curative and rehabilitative to promoting mental health and increasing early detection and prevention, as well as better case management at the primary care level. Chair and colleagues, the highlight of this Global Health Summit, advancing community-focused approach to mental health, is fit with our transition. Therefore, it is our high interest to listen to all the experience and knowledge sharing from other countries presented since yesterday. For this, we thank the organizers. On our part, our current mental health infrastructure has not been adequate to plan sufficient seats for a strong community-based mental health approach. To date, only 47% of our primary health care have the capacity to run mental health service and program. We will accelerate this achievement so that by 2024, our 10,321 primary health care will be able to provide mental health service and run mental health program. On a positive note, at the primary healthcare level, there are many innovations in empowering people with mental disorder who have recovered so that they can be independent and productive. Mental health promotion in the community is carried out through community health activities called Posyandu. These integrated village health activities, or Posyandu, are carried out by community health cadres. The mental health promotion is also carried out through school health program. Further, at the district, province, and national level, we have established a team responsible for community mental health as regulated by the Mental Health Law Year 2014. This team is called Community Mental Health Steering Team. The team is headed by the Vice President at the national level, Governor at the province level, and Mayor at the district level. The team consists of different ministerial lines, professional organizations, and representative of communities. Indeed, the role of this team is strategic for promotion and prevention and management of mental health. I do hope with this architecture of mental health and its agenda, we are in the right direction towards stronger community mental health program. Chair and colleagues, in this occasion, it is key to re-emphasize the collective commitment to strengthen comprehensive, integrated, and sustainable mental health service and program through community-focused approach. To conclude, we invite partners, academics, and civil societies to work with us on this mission. Thank you very much.
Thank you, distinguished delegate of Indonesia. Now the floor to the distinguished delegate of Canada, followed by the distinguished delegate of Japan. Please, Canada, the floor is yours.
Thank you all, and to the distinguished delegates, but I particularly, it's been 70 years since Dr. Brock Chisholm was the first Director General of the WHO. He was a Canadian war veteran who said that there could be no true health without mental health. And I want to thank the WHO and thank all of the organizers of this summit for getting us all back on track. This is, we believe that this is a rights-based approach, and that we, as I said yesterday in the panel, as a colonized country, have heard and are still paying the price for not understanding Indigenous rights. And so as we go to First Nations, Inuit, and Métis rights, the rights of people with disabilities, the rights of two-spirited and LGBTQIA+ people, women's rights, children and youth rights. We are fighting in Canada systemic racism and discrimination, and that we are doing that in all of our institutions. The intersectionality of these people with varying disabilities and discrimination really needs specific attention. But we also have learned from COVID that there's a digital divide, that when there are abilities to help people at a distance in our big, huge country, that we actually can't tolerate anymore the idea that people wouldn't have access to internet and those modalities. In the skills, I think that we have to start with the attitude, that this is about dignity. We need all of us to understand that we have to listen to those with lived and living experience, but we also need, in our big country that relies so much on migration and immigration, that we have to have culturally safe approaches that are trauma-informed, and that we need to raise the mental health literacy of all Canadians, such that we can actually move to that stepped care model that starts with self-care, that then moves to the peer counseling and the peer supports, moving up into much improved mental health in primary care and that as we go forward, the most appropriate care in the most appropriate place by the most appropriate person at the most appropriate time. And that means evidence, and it means we actually have to have the data to decide what's appropriate. And so I thank you all very much for this, and we're all going to try and do better.
Thank you, distinguished delegate of Canada. Now the floor to distinguished delegate of Japan, followed by the distinguished delegate of Lebanon. Please, Japan, the floor is yours.
Japan welcomes the fact that mental health is increasingly on the attention friend stakeholders within any following COVID pandemic. No fruitful discussion in the thematic groups. Japan would like to comment on several points. Regarding mental health promotion in Japan, we would like to explain our footsteps in suicide prevention. In 2006, we adopted the Basic Act on Suicide Countermeasure, and the national government became the head and collaborated with the local governments and the non-governmental organizations. The number of suicides continued to decline from 2010 to 2019. However, after the COVID-19 pandemic started, the number increased in 2020, and it increased further for women in 2021. In order to deal with the problem of loneliness and isolation, which is considered to be one factor in the increasing number of suicides, Minister in charge of measures for loneliness and isolation was newly appointed in 2019. We wish to raise awareness on this complex issue within the global community. As the number of psychiatrists steadily increases and the stigma against mental illness eases in Japan, the promotion of people with mental illness accessing healthcare has increased from 15% in early 2000s to 23% in mid-2010s, according to the World Mental Health Survey, Japan. Despite the effort to increase access to mental health care in general, there remains a challenge in the community-based integrated care system in Japan, as in many other countries. Internationally, we are conducting several bilateral technical assistance projects in mental health, including a project on rehabilitation for stimulant users in the Philippines, and one on preventive interventions for youth in Jordan. We have also funded several mental health research projects with low and middle income countries. Through Global Alliance for Chronic Disease, such as a study on workplace digital mental health intervention for nurses in Vietnam. Although these projects can develop new interventions and train the workforce within the country, it is essential that each country invest more in the mental health systems and contribute to the universal health coverage. We look forward to more exchange of experiences in mental health policy and practice with many countries through Global Mental Health Summit, as well as international organizations in the future. I thank you. Thank you.
Thank you, Japan. Now the floor to the distinguished delegate of Lebanon, followed by the distinguished delegate of Liberia. Please, Lebanon, the floor is yours.
Excellencies, on behalf of His Excellency Minister of Health, Dr. Firas Abyad, I would like to thank the government of Italy for hosting this summit. Lebanon is facing multiple unprecedented crises, causing much suffering, weakening the health system, and pushing many qualified health professionals outside the country. Yet we've been successful at preventing the worst, and we can still provide a significant proportion of the services that the health system provided before. When it comes to mental health, Lebanon has been working on reforming the mental health system for the last few years. Much has been done, but much more is still to be done. Mental health was and still a priority for the Ministry of Public Health, but given the competing priorities, the increased demands on the health system and the economic crisis, we will not be able to continue the reform alone. We need the international community support if we are to see this reform through. We're grateful to all our partners who supported and collaborated with us, namely WHO, UNICEF, UN agencies, local and international NGOs. I would like to acknowledge here the support of the French government. This support allowed the National Mental Health Program to continue its operation and respond to the COVID crisis while continuing the work on the reform. Also, I would like to acknowledge the timely support from the Dutch government after the Beirut port explosion that helped and is helping in scaling up services. I'd like to take a moment here to speak in my name to express my gratitude to Dr. Firas Abiad for his leadership and commitment to mental health. Without his support, especially in these difficult times, I am sure we wouldn't have been able to do what we were able to. I would also like to acknowledge the National Mental Health Program team for their dedication and hard work, day in and day out. They are the real force behind the work of the program. Finally, I would like to reiterate Lebanon's commitment to the vision of the National Mental Health Strategy, that all people living in Lebanon will have the opportunity to enjoy the best possible mental health and well-being. We look forward to more collaboration and cooperation with you to advance mental health for all. Thank you.
Thank you, distinguished delegate of Lebanon. Now I give the floor to the distinguished delegate of Liberia, followed by the distinguished delegate of the Netherlands. Please, Liberia, the floor is yours.
On behalf of our President, Dr. George Manawia, and our Minister of Health, Dr. Wilmina Jala, I would like to extend our profound thanks and appreciation for this opportunity and the focus on mental health, as any progress made will bring change to the most vulnerable amongst us. Our commitment remains strong, for we realize that if mental health is to be prioritized, it must be financed and integrated into the long-term strategy for Liberia. As victims and survivors of war, Ebola, and COVID, we know well that the victims of mental health that we see daily, if not assisted to recovery, will only continue to drain our economic capacity as a country and hurt our human capital growth index. A recent study assessing the economic impact and return on investment in mental health in Liberia estimates that the total number of productive days lost due to poor mental health amounts to about 5.3 million annually, reducing our economic output by 32.9 million per year. Due to the scope of the size of Liberia's economy and informal sector, which is estimated to be about 30 to 40% of the GDP, this figure does not fully account for our lost economic output and is likely underestimated. However, our focus remains on funding the critical gaps in human resources, sustainable financing for mental health, and improving services to promote, prevent, and treat this population. Research has also shown us that if we spend just 50 cents per person, we could avert 38,470 cases of mental health disorders, which is an estimated 45%, which would relate to members of the labor force, restoring 176,999 productive days of economic activity, and subsequently delivering $1.1 million worth of increased economic output for our economy. So we have every reason to recommit to this cause, and we thank you for the opportunity to share our experience, progress, and plans. I want to say thank you to the Carter Center, our committed partner, the U.S. government, and other partners for their sustained support and commitment to improving mental health in Liberia. I thank you.
Thank you. Thank you, distinguished delegate of Liberia. Now I give the floor to the distinguished delegate of the Netherlands, followed by the distinguished delegate of New Zealand.
Excellencies, dear colleagues, thank you very much. A couple of years ago, 3 years ago, the Netherlands hosted the second Global Mental Health Summit under the title Mind the Mind Now, Mental Health and Psychosocial Support in Crisis Settings, leading to a rich set of recommendations, the implementation of which we continue to monitor and stimulate. And developments since then only served to confirm the importance of attention for mental and psychosocial needs in crisis. The Netherlands highly appreciates that this current summit in many ways focused on how to address mental and psychosocial needs in crisis settings, any kind of crisis in any part of the globe, and on how to work together on smart ways to increase skills across the globe to provide quality, rights-based mental and psychosocial care in any setting, because the needs are increasingly being expressed and recognized. If we want to be resilient under the many crises facing us and those looming ahead, we need to be prepared for the mental and psychosocial effects of crisis. Mental and psychosocial well-being are a core enabling factor for resilience and ability to respond to and recover from crisis and from pandemics. Our societies need to ensure that mental and psychosocial needs are addressed. The community-based approaches discussed these 2 days provide very feasible entry points to increase inclusive ways of psychosocial support, among which peer-to-peer counseling. And this is not a task of the health sector alone. In humanitarian settings, rich, multi-sectoral experience and evidence has been gathered, and many tools have been developed which can be of use for any actor in any sector and in any setting in preparing for emergency mental health and psychosocial needs. Thus, among others, there's the Dutch Rapid Deployment Mechanism, which is providing experts that support cooperating humanitarian organizations in integrating and coordinating MHPSS in the response in specific crises. This is a mechanism which, with your help and cooperation, could be developed to respond to more varied situations and needs. Because we need to do this together, allow me therefore, building on the outcomes of Mind the Mind Now in 2019, of the Paris Summit last year, and of yesterday's session on emergency preparedness, to reiterate a call for a multi-sectoral and whole-of-government approach for cooperation, co-creation, and co-funding of MHPSS inclusive emergency preparedness and response, as well as cross-sectoral shared investments in skills development and deployment. I thank you.
Thank you, distinguished delegate of the Netherlands. Now the floor to the distinguished delegate of New Zealand, followed by the distinguished delegate of the Philippines. Please, New Zealand, the floor is yours.
Thank you, Mr. Chair, and my thanks to the Italian government and the organisers for convening us at this important summit today. Aotearoa New Zealand is pleased to see the progress being made to support global mental well-being. I'm also heartened to see the topics covered here at the Global Mental Health Summit. For example, taking a community-focused approach to mental health, involving people with lived experience in their families, and emphasising human rights and dignity of people affected by mental health conditions. These topics form the basis of significant work program we have underway in New Zealand to transform our approach to mental health and mental well-being in Aotearoa, New Zealand. I join my colleague from Canada in also noting the importance of our post-colonial context, and in New Zealand that means continuing to meet our obligations under Te Tiriti o Waitangi. Mental wellbeing is a priority for our government. Since the release in 2018 of He Aranga Ara Oranga, the government inquiry into mental health and addiction, our focus has been on ensuring that everyone in New Zealand can access mental health and addiction support where they need it, when and how they need it. In 2021, the government released New Zealand's first whole-of-government strategy and action plan to improving mental well-being, Kia Manawa Nui Aotearoa long-term pathway into mental well-being. Kia Manawa Nui reinforces the need to build the cultural, social, environmental and economic foundations of mental well-being. We know supporting mental well-being of New Zealanders does not and cannot rest solely on the health system. Cross-government coordination and investment is also key to addressing the social determinants of mental well-being to support more mental health and addiction solutions. Across government agencies, within communities, businesses, schools, churches and homes, each of us has a role to play. For New Zealand, a missing part of the puzzle has been support for people with mild to moderate mental health and addiction needs. We are addressing this by rolling out primary mental health and addiction services within general practice across the country and targeted community-based services for Māori, Pacific, youth and rainbow communities. We have a broad program of work underway to both grow and upskill existing workforces and to develop a diverse range of new workforces. This includes a strong focus on peer and cultural support workforces. Along with providing services targeted at specific populations, we are also determined to improve the cultural competency of our workforce for Māori, Pacific and Asian communities. As well as these service developments, we are repealing and replacing New Zealand's mental health legislation to improve the protection of individual rights and incorporate our obligations under Te Tiriti o Waitangi. We are taking an ambitious approach and will continue to push for positive momentum in mental well-being in Aotearoa. We are encouraged that action underway on mental well-being is already making a significant difference for New Zealanders, and we are committed to the long-term vision of an equitable and thriving Aotearoa in which mental well-being is protected and promoted. Ngā mihi nui, tēnā koutou, tēnā tātou katoa.
Thank you, New Zealand. Now the floor to the distinguished delegate of the Philippines, followed by the distinguished delegate of Romania. Please, the Philippines, the floor is yours.
Good morning. On behalf of the Philippine government, I would like to thank the government of Italy for hosting this event. As the Philippine Department of Health continues to fulfill its mandate to lead the health sector, its National Health Sector Strategy 2023 to 2028 will focus on policies and programs that will enable Filipinos to be healthy, protect Filipinos from health risk, care for Filipinos' health and wellness, and strengthen health institutions and workforce. With the passage of our country's mental health law in 2018 and the Universal Healthcare Law in 2019, the Philippines is committed to advance community-focused approaches to mental health services, while at the same time ensuring that these services are made available across the continuum of care delivered at different levels. We acknowledge the challenges in accessing mental health services as a specialized practice, considering the low number of psychiatrists and other mental health professionals in our country, coupled with the issues of global mobility and migration of our healthcare workers. Further, stigma and discrimination among service users is still apparent, and a more deliberate communication and advocacy plan can help increase awareness and acceptance. Recognizing these challenges, we have adopted a non-specialized approach to bring mental health services closer to our communities, utilizing WHO's Mental Health Gap Action Program Intervention Guide as a tool in training primary care service providers, complemented with a robust medicines access program. We have reached clients in communities unable to seek care in our hospitals. However, medicine access in low and middle income countries remain an issue, and we hope for stronger global cooperation to ensure equitable access to life-saving medicines. We now move towards a settings-based approach in delivering quality mental health care, considering that mental health is also multifactorial. We support and request the global community to advocate for healthy learning institutions, healthy workplaces, and healthy communities through policies and implementation protocols that will address broader social dimensions of mental health. This direction is in line with the global strategy to shift to a generalized community-based mental health care. Promotion and prevention activities shall be scaled up in the community settings, empowering members of the communities to utilize their existing resources to make mental health care available. Linkage to primary level up to higher levels of care shall also be ensured, allowing service users to have more access to appropriate and quality mental health care that they need. Mental health problems are complex issues that need systems intervention. The Philippines is one with our global partners in strengthening the health systems and fully engaging policymakers and members of society to increase mental health awareness and commitment. Having a common understanding of our desired reality for mental health is stronger with a shared vision to address health inequities and the societal divides. Thank you.
Thank you, distinguished delegate of Philippines. Now I give the floor to the delegate of Romania, followed by the distinguished delegate of Saudi Arabia. Please, Romania, the floor is yours.
Good day. On behalf of Ministry of Health from Romania, I salute the organizers and the colleagues all over the world present here. Since 2007, when Romania became member of European Union, the Ministry of Health was preoccupied to develop mental health services in a modern vision by decentralizing the treatment based on hospitalization towards communities. On May 2019, Ministry of Health proposed and the government passed a law that established the new structures involving community health care, their attributions, and level of salaries for the employees funded by the state budget through local administrative authorities. Our last statistics at the end of year 2021 indicated that now in function are 54 centers with 2,026 employees of community nurses. The community medical nurses are providing services for vulnerable groups, people with physical disabilities, elder persons with chronic diseases, chronic psychiatric patients, unemployed persons. First steps are done by Romania to develop mental health services in community. Annual evaluation done by now show that they are useful and effective. We shall continue to develop them, take into consideration the recommendation for government that was done at this summit. Ministry of Health in Romania is continuing its efforts to offer quality mental health services affordable and accessible through those in need, respecting human rights and dignity. Ministry of Health is stating his commitment to achieve the aim of community well-being through sustainable reforms. In the end, I would like to express our appreciation for the Ministry of Health from Italy that gave us the opportunity to share experience, knowledge, and networking today. Thank you.
Thank you. Thank you, distinguished delegate of Romania. Now the floor to Saudi Arabia, followed by the distinguished guest of Slovenia. Please, Saudi Arabia, the floor is yours.
Thank you. Mental health is highly preventive and covers a variety of psychiatry and addiction disorder that is suffering from. impact of mental illnesses is negative in our societies, causing a loss of productivity, safety issue such as suicide or assistive behaviors, healthcare burden, and costly, even shortening the age of patient with physical complications. In our country, Saudi Arabia, mental health has been a priority since we established the first mental health hospital in 1952. As you may know, Saudi Arabia is a big country, so we set up a specialized mental health hospitals in 19 different cities, trying to maximize the affordability of the services for citizens and residents. We believe the demand of psychiatry services is increased and continuing like that, so we opened a psychiatry division in 148 hospitals and general hospitals in Saudi Arabia. Mental health services are provided in the majority of primary care centers in the kingdom. The pathway follows our model of care in that the patient will start his journey with care in the nearby primary care centers. Then if they require further interventions such as specialized or not available kind of care, he will squalid for services in secondary hospital, then the tertiary hospital or specialized mental health hospital. During COVID-19, it was obvious that the patient would not be able to take services, especially during quarantine. The Ministry of Health encouraged telemental health psychiatry services through the Sihati app and Anat app to provide it from all psychiatry clinics, and medications will be delivered by Saudi Post. Digital mental health opened channels with psychiatry patients and made services easy to get and elevated the level of adherence to the treatment plan. We also have the first national virtual hospital where all kinds of services are provided, including subspecialties services like child psychiatry, psychosomatic, forensic, and addiction psychiatry. During the COVID-19 pandemic, there is a national helpline, 937, in the Health Ministry for counseling. The Psychology Council team plays a significant role in reassuring patients and the public, advising and guiding them to have the right and fast services. The 19 mental health hospitals open a counseling centers and provide tele-mental health for patients. All of those during the pandemic built the broken bridge between patients and the healthcare system and opened a new era of expanding more digital health systems. In the Ministry of Health, there is a lot of starting initiatives since 2018, including opening psychiatry inpatient divisions in the general hospital, where it increased gradually till we reach 350 divisions. Opening psychiatry, OBD, in the general hospital in 148 hospitals. Opening child psychiatry department in 4 regions. Opening halfway houses for addiction rehabilitation in 13 mental health hospitals, and initiating a pathway for treating addiction in all psychiatry clinics. Clinical guidelines and protocols, suicide prevention, schizophrenia, bipolar, dementia, obsessive-compulsive disorder, addiction treatment, depression, etc. Lastly, we have a Ministry of Health strategy for mental health, addiction, and developmental disorder, where we address all needs and gaps in the mental health. Thank you.
Thank you, distinguished delegate of Saudi Arabia. Now I give the floor to the delegate of Slovenia, followed by the distinguished guest delegate of Thailand. Please, Slovenia, the floor is yours.
Excellencies, ministers, distinguished delegates, the Global Mental Health Summit plays an important role in raising the awareness of decision makers about the importance of mental health at the global level. Therefore, on the behalf of the Republic of Slovenia, I would like to thank the organizer for this event. The COVID-19 pandemic has not only exposed all the shortcomings of existing policies and services in the mental health, but also increase the mental health burden. These effects will reverberate for many years. Effective measures and approaches in strengthening and protecting mental health are crucial for the progress of society and economic growth. Slovenia made significant progress in the field of mental health in 2018, when first national mental health program was adopted. In National Mental Health Plan, Slovenia followed WHO guidelines about organization of services and their interconnection in geographically defined areas. The National Mental Health Program introduces a comprehensive way of addressing mental health in Slovenia by first shifting the focus of treatment from the secondary health level to the primary health level and supporting high-quality, comprehensive and accessible treatment of people with mental disorders in community mental health centers. Second, strengthening a cross-sectoral cooperation with the network of services and all important stakeholders, including users and relatives. And the third, strengthening the promotion of mental health and prevention of mental health problems. Mental health centers in the community establish multidisciplinary team treatment and connect the services of other sectors and other stakeholders in the local environment. Mobile home treatment teams are also an integral part in these centers. We have planned to set up all 50 centers within 10 years. However, due to the great needs of the population on one hand and the ability to stay open and accessible all the time of pandemic on the other hand, we exceeded our plans. Today in Slovenia, there are already 36 centers, 20 for mental health for children and adolescents and 16 for mental health for adults. Unlike institutions, community mental health centers remained accessible and active through the epidemic and further confirmed the need for reform by shifting the focus of treatment of persons with mental disorders to the primary health care level in the local environment. Therefore, I welcome the decision of the organizers to dedicate the 4th summit to the promotion of the treatment of mental disorders in the community. Thank you for your attention.
Thank you, distinguished guest, delegate of Slovenia. I give the floor to the distinguished delegate of Thailand, followed by the distinguished delegate of the United Arab Emirates. Please, Thailand, the floor is yours.
Thank you, Chair. First of all, let me express my sincere thanks to this Global Mental Health Summit. We learned a lot. Recognizing the mental health is essential for well-being, especially during the pandemic. Thailand surveys closely on the impacts of COVID-19, in which we have found that the demand for the mental health services is significantly increasing. Like most of the countries, Thailand reported widespread disruption for many kinds of critical mental health services. There's been the disruption to services for vulnerable people, including the children and adolescents, older adults, and women, as well as disruption to access for medication for mental, neurological, and substance use disorders. To overcome this crisis and prevent psychological problems such as anxiety, depression, and suicide, Thailand encouraged communities and networking to be involved in mental health and psychological support. Community-based mental health is a necessary part for providing promotion of mental well-being, prevention of mental health problems, process of mental health care and recovery. Thailand emphasizes 2 points on community mental health, which related to the WHO Comprehensive Mental Health Action Plan 2013 to 2030. Firstly, we urge the countries to focus on community mental health as a key intervention to strengthen mental health and well-being in general population and to protect vulnerable people or risk groups. We need to promote mental health literacy and awareness, as well as reduce the stigmatization for strengthening community resilience and encouraging our networks, partnership, and community members to work together. Ultimately, it makes people feel safe, calm, and hopeful. Also, they will be willing to take care of each other and lead to overcome the crisis and decrease mental health problems. Secondly, Thailand tries its best to promote evidence-based primary and community mental health services and psychosocial support, which boosts the community resilience and engagement. Lastly, we also request countries to provide and exchange or share technical support, as well as lessons learned to strengthen our partnership. Thank you very much.
Thank you, distinguished delegate of Thailand. Now I give the floor to the distinguished delegate of the United Arab Emirates, and it will follow by a pre-recorded video from the delegate of the United States of America. Please, United Arab Emirates, the floor is yours.
Thank you. To begin with, I would like to congratulate Honorable Roberto Speranza and the government of Italy for successful hosting the Global Mental Health Summit in the city of Rome. The unprecedented COVID-19 crisis exacerbated the vulnerabilities within the global mental health service provision spectrum. During the pandemic, access to mental health services was a fundamental issue, along with an increase in number of patients seeking mental health services. Although significant strides have been made to enhance mental health services provision since the beginning of the pandemic, a lot more has to be achieved in order to reforming and strengthening mental health services provision at national, regional, and global levels. Emphasis has to be held on promoting and applying a whole-of-society approach to mental health. Targeted campaigns need to be conducted to create additional awareness of mental health and to deal with the stigma towards people with mental health problems. In particular, access to care has to be enhanced through innovative and virtual solutions, and a community-based approach to mental health service provision needs to be adopted. The United Arab Emirates promotes mental health by providing comprehensive and distinguished mental health services in a sustainable, healthy environment and in accordance with effective policies, legislations, and programs to all categories of patients, including but not limited to children and adolescents. A key pillar of the UAE National Mental Health Strategy is developing, strengthening, and expanding comprehensive, integrated, and socially responsive mental health service for the UAE society, which includes a focus on transfer of mental health services from standalone facilities to primary and community care, capacity development through increasing mental health knowledge and skills in all health care professionals, and driving innovation in patient-centered care to improve efficiency, quality, and affordability of mental health services for all. It underlines the importance of using technology to foster collaboration, increase access to service, and engage people in managing their mental health problems or illnesses. UAE has adopted innovation and digital transformation in delivering mental health services using virtual care, AI-assisted clinical decision support tools, digital applications, and telemedicine. These innovations have shown an improvement in mental health outcomes, patient empowerment, and access to care. Building on the lessons learned from recent times and based on the fruitful discussion and recommendation which held yesterday, adopting a whole-of-a-society, community-based, innovative, and inclusive approach has the potential to significantly enhance mental health service provision across all contexts. Thank you.
Thank you, distinguished delegate of the United Arab Emirates. And now we are going to watch the video, record video of the delegate of the United States of America. And it will be followed
Greetings
by
to all in attendance.
Zimbabwe.
A special thank you to Italy and the WHO for hosting this summit and bringing us all together to work on such an important subject. When it comes to health, the world is at a crossroads. COVID accelerated our arrival here, but make no mistake, the reckoning was coming. Across the world, the mental health of our communities has precipitously declined. We can't hide it, we can't avoid it, and for the sake of our loved ones, we must not ignore it. In America, and I hope everywhere in the world, I believe that means we are ready to finally and seriously say, mental health is health, period. No distinction. So if we provide health care, that should unquestionably and inextricably include mental health care. In the US, under President Biden, we have the chance to make a real and life-changing difference for people who are struggling with their mental health. 90% of Americans today are telling us that the US is experiencing a mental health care crisis. I hear this throughout my travels, from doctors to teachers, parents to students. Under President Biden, we have expanded the reach of our 1,400 community health centers, which provide care to millions of patients regardless of ability to pay. And we are expanding certified community behavioral health clinics, which provide crisis services that are available 24 hours a day, 7 days a week. One of our major initiatives, and one that I am particularly proud of, is our work to transition America's 10-digit national suicide prevention telephone number to a 3-digit number, 988. In America, when you or your loved one needs help, you need only dial 988. In 988's first full month in operation this past August, 216,000 people sought help through the 988 lifeline, compared to 140,000 who used the 10-digit telephone number just 1 year prior. 988 isn't just a number. It's a message to Americans that we are there for you in your moment of need. That must be our message to all of our citizens. COVID reminded us that no one is safe until everyone is safe. As a community of nations, we have a chance to prove to all of our peoples that we will work to keep them safe and healthy. And when we say health, by right and respect, we mean mental health without exclusion. Thank you for allowing me to address you, and blessings to all.
Thank you to the US delegates, and now I give the floor to the distinguished guest of Zimbabwe, followed by the distinguished guest of Congo.
Thank you. No, it's okay. No. Thank you, distinguished delegates. As Zimbabwe, mental health issues are common. Definitely, we lived under colonialism for a long time, and now we are suffering under the sanctions illegally imposed by the United States of America and Britain. Even though in 2020, we launched the special initiative for mental health, which aims to improve service delivery through capacity building and community mental health. We also launched the first Zimbabwean mental health investment case, which we completed in July 2022. The investment case is going to help Zimbabwe to increase funding in mental health. By investing in mental health now, Zimbabwe could gain economic benefits of 175 million in the next 10 years and 689 million in the next 20 years. Regarding community health, mental health, we have established family support parenting programs in 23 districts, a community treatment support center, a peer supporter for adolescents living with HIV. This cadre has helped to improve treatment outcomes among adolescents living with HIV. We have since adopted the French bench model in Zimbabwe, born intervention, where village health workers are trained to offer mental health screening and problem-solving therapy while sitting on a bench. Regarding workplace mental health, we have established and continue to train a cadre called Workplace Mental Health Champion. This is a volunteer at a workplace who is trained on common mental health disorders, basic counseling skills, problem solving, therapy, and when and how to refer. We have an interministerial task force of people in transit and victims of human trafficking. Regarding the rights of people living with mental health conditions, we trained 1,040 care workers on World Health Organization quality rights in 2021, and 500 people living with mental health have received the same training. And we are aware mental health is a big NCD which should be looked at together with other bigger NCDs like diabetes, hypertension, cerebrovascular accidents, and all others. I thank you.
Thank you, distinguished delegate of Zimbabwe. Now I give the floor to the distinguished delegate of the Democratic Republic of Congo, followed by the delegate of Nigeria. Please, the Democratic Republic of Congo, the floor is yours.
Merci, Monsieur le Président. Mesdames et Messieurs,
Thank you, Mr. President. Ladies and gentlemen, thank you for the kind invitation. The Democratic Republic of Congo is really very happy to participate in this high-level summit on mental health. As a Minister of Health, I can say that this is an issue that we are much concerned with, and that's why I would like to warmly thank you for the kind invitation. The whole world is taking up the challenge of mental health, which has repercussions on the life of people involved. Mental health is part of health and well-being in general. Therefore, it is a fundamental human right. There is no health without mental health, as we say. And in addition to public health and humanitarian emergencies, climate crisis, wars have further exacerbated the problems of mental health, in addition to emergencies from COVID-19 pandemic that undermined mental health of people all over the world. In our country, at least 22 million people in Congo suffer from mental health disorders, especially in the eastern part of the country, due to wars, due to natural catastrophe, due to the reoccurrence of epidemics such as Ebola, and due to exacerbation of sexual abuse perpetrated by armed groups coming from neighboring countries, causing traumas to our populations. Because this practice of continuous violence and abuse, unfortunately, obviously causes problems, mental health problems in the eastern part of Congo. And but the Minister of Health and the government tried to improve mental health and improve the treatment of people suffering from mental diseases at all levels. And the implementation and dissemination of mental health policies policy within a universal mental health vision, and with the integration of this within primary care, and the capacity building for all healthcare providers. We have dealt with different mental health issues, and there has been involvement of the communities, including all the people who have an expertise in the field of mental illnesses to fight against stigma and discriminations. There is an actual lobby at a lobby has been developed in the ministry to increase the budget, health budget, which has reached 14%, thus coming close to the desired goals. Mental health coverage is still low, estimated 5%, so much has still to be done. There is much room for improvement considering the stakes, but our determination, our resolution and investments available for the universal health coverage, we will come to the standards required, and we will make
of the Democratic Republic of Congo, the distinguished delegate of Nigeria, followed by the distinguished delegate of Uganda. Please, Nigeria, the floor is yours.
Thank you, Mr. Moderator. I wish to join other delegates in thanking the government of Italy and the World Health Organization for organizing this very useful summit, from which we have learned quite a lot. This is helpful and comes in useful as we embark on broad reforms of our health system in Nigeria. The learning moment in mental health provides opportunities to leapfrog, to avoid errors which advanced health systems are discovering, and to build considered improvements into our own health reform. The focus of our reform in Nigeria is on expanding and improving the quality of primary health care towards universal health coverage, and also improving health financing and secondary and tertiary care. We are also setting up a medical emergency medical service, one of the few that will be functional in Africa. We have plans to build mental health care into the basic health care at primary level, a service which we had hitherto reserved for the conflict areas in the conflict areas in the northeast. As you know, our country is racked by the Boko Haram insurgents, but such service should clearly be available nationwide. A new law is under development to replace the colonial law of 1958, which was called the Lunacy Ordinance. Nigeria, like most African countries, has been affected with the 3 C's: climate, COVID, and civil conflict, which have seriously affected social services and contributed in no small mass to illegal emigration. There is no doubt that these factors are the precursors for psychosocial challenges, especially among the youth. And if you add to that the temptation to join experimenting with drugs, then you have a perfect storm for mental health problems. But it doesn't also leave out the elderly or even the young ones. I noticed that the presentations yesterday did not include opportunities for African delegates to highlight their issues or to share in their experiences and presentations. I think the Global Mental Health Summit should take on a more inclusive appearance going forward and make it truly global, allowing for all areas of the world to present their own experiences. Development of human resources for health, armed with task shifting and task sharing, is a priority, especially in expanding services. we shall be expecting more international collaboration in all these regards, especially in the area of developing policy and strengthening human resources. Thank you for your attention.
Thank you, distinguished delegate of Nigeria. Now I give the floor to distinguished delegate of Uganda, followed by the distinguished delegate of the IOM. Please, Uganda, the floor is yours.
Thank you so much. On behalf of my country, the Republic of Uganda, and on my own behalf, the Minister of General Duties, Minister of Health, allow me to appreciate the government of Italy, the organizers, and distinguished delegates. I wish to begin with a keynote that while globally COVID-19 had devastating social, economic, and environmental effects, it has also had a notable positive side of unification of nations in relation to health. Two, it has exposed weaknesses in the countries and nations' health systems that led to the world to appreciate that physical health cannot be addressed individually without mental health, as many have said. And therefore, mental health is health, and physical health is a human right that is not delegatable. Today, we are gathered here to share experiences and best practices in addressing issues of promotion of well-being of our populations, as well as reduction of the burden of mental, neurological, and substance use disorders through improved access to quality, preventive, curative, and rehabilitative services. Globally, we note that mental, neurological, and substance use disorders are on the increase in the post-COVID era. For example, in Uganda, 25 to 45% of consultations in our facilities are due to mental disorders, such as epilepsy, unipolar depression and bipolar disorders, psychosis, anxiety, and post-traumatic stress disorders. There is a lot of psychological stress, especially among children and adolescents, and those holding the political positions. The intervention so far made in Uganda is, first of all, number one is there is political willingness to prioritize and listing mental health on the political agenda. Number two, at the legislative level, that is at parliament level, formulation of mental health related policies and laws, such as Mental Health Act, Tobacco Act, the Alcohol Act policy, and the non-communicable diseases, and the mental health strategic plan, which are very vital in reduction of the burden of the health, mental health, and related issues. Number three, Uganda has put in place strong mechanisms for implementation and enforcement of the above policies and laws that has largely contributed to reduction of mental health in the country. Number four, there is strong mental health surveillance mechanisms that have enabled the country to detect, coordinate, and monitor mental-related issues. The country's strengthening of capacity for leadership and coordination of mental health services at all levels of care. At parliamentary level, there is a small mental health parliamentary forum for advocacy, lobbying for increased funding for mental health and review of mental health-related laws. At central level, there is a multi-sector national mental health and psychosocial support working group for proper coordination of services. Streamlining quality mental health services at facilities of level and within the communities, with a structured referral system from health center tools to national and regional referral mental health services. Creation of awareness and education of the population on mental health, which helps in reducing stigma, discrimination, and ultimately enabling people with mental disorders to seek for treatment, support, and rehabilitation. Strengthening and provider user linkages of collaborative care is very vital in Uganda. This has enabled client-centered care provision. accurate data collection, storage,
may you
and
conclude,
information
please.
dissemination, which is very vital in planning and budgeting for mental health financing sustainability. In conclusion, there are some mental health reforms being undertaken in Uganda. However, there is still a need for increased funding for mental health services, and I call upon international communities and governments to invest more in mental health, especially community-focused approaches. I thank you for your attention. Thank you.
Thank you, distinguished delegate of Uganda. Now I give the floor to this distinguished delegate of IOM, followed by the distinguished delegate of the WHO. Please, IOM, you have the floor.
Thank you very much. Distinguished ministries, excellencies, colleagues, on behalf of Antonio Vittorino, Director General of the International Organization for Migration, I would like to thank the Ministry of Health for organizing and hosting the 2022 Global Mental Health Summit, and in particular for giving space and attention to the mental health needs of people on the move, opening this way a discussion on the asymmetric access to mental health care that migrants, refugees, asylum seekers, and stateless people encounter everywhere in the world. IOM, through its dedicated mental health, psychosocial response, and intercultural communication global division, is committed to promoting the mental health of migrants in line with provisions set in the Global Compact for Safe, Orderly, and Regular Migration and the Agenda 2030 for Sustainable Development. IOM brings a workforce of over 600 mental health and psychosocial support professionals in over 80 countries that in 2021 alone have provided support to over 1.5 million migrants, asylum seekers, refugees, stateless people, internally displaced, victims of trafficking, returnees, and host community members. Excellencies, ladies and gentlemen, too often migrants experience barriers to access adequate mental health care, and when they do have the right to access care, they are sometimes hesitant to utilize services due to language and cultural barriers, lack of awareness about their existence, lack of trust, a fear of stigma and discrimination, or to be detained in case of irregular status. In this context, IOM wants to reiterate its strong commitment in line with the recommendation emerged from the summit to continue supporting its member states and professional associations, service providers, and migrant communities in first, ensuring, advancing, advocating for access to primary, secondary, and tertiary level of mental health care to all migrants, irrespective of their legal status. Second, mainstreaming mental health care and primary health care and within emergency response. Third, offering services and promoting policies that open mental health care services to diversity and diversity competence. Fourth, mainstreaming mental health and psychosocial support in all systems relevant to migrants' access and outreach, such as education, employment, law enforcement, and social care. And fifth, promoting the active inclusion of migrants in mental health legislation, policy, and program development. Our country offices all over the world are available and committed to assist, so please do reach out. Thank you.
Thank you, distinguished delegate of the IOM. And now I give the floor to the distinguished delegate of the WHO to conclude the first session of programmed interventions. Please, WHO, the floor is yours. Thank you.
Thank you so much. Dear honorable ministers and distinguished delegates, I'm pleased to contribute to this high-level segment on behalf of WHO Director General Dr. Tedros. I'm Deborah Kestel, the Director of the Department of Mental Health and Substance Use. As Dr. Tedros pointed out in his welcoming remarks, even before the pandemic, nearly 1 billion people around the world were struggling with the mental health conditions. Despite such a high prevalence, people with these conditions are largely uncared for, frequently stigmatized, discriminated against, and pushed to the margins of society. The multiple impacts that the pandemic has had on the population's mental health has forced a major rethink in many countries. They were not prepared to handle the vast mental health needs, and their existing mental health system was weak and heavily concentrated on specialized hospital-based services. So I would like to take this opportunity to thank WHO's member states, many of whom are here today, for their renewed commitment to mental health, shown both at the national level through new initiatives, as well as at the international level through the endorsement of frameworks for action on mental health brought before WHO's regional and global governing bodies. Renewed commitment and value to mental health is a vital prerequisite for meaningful change on the ground. It is one of the 3 pathways to transformation identified in our World Mental Health Report. Such value and commitment is also about including people with mental health conditions in all aspects of society and decision making. Crucially, for you as key decision makers in your countries, it is also about stepping up investments in mental health with financial and human resources and evidence-based policies that upholds your human rights. Beyond political commitment, we need to see significant financial commitment to advance mental health care. In the World Mental Health Report, we explained what such a network of services look like, how it can be developed, and what it can achieve. This report is primarily written for you, to support you in implementing the WHO's Comprehensive Mental Health Action Plan 2013-2030. Although most countries do not have the resources to implement all actions described in the report or during this summit, every country has ample opportunities to make meaningful progress towards better mental health for its people. Thank you.
Thank you, distinguished delegate of the WHO. So, dear colleagues, now we have concluded the round of program interventions, and we will move to the head of delegations that presented their interest to speak. The next speaker is then the distinguished delegate of Bangladesh, followed by the distinguished delegate of Cyprus. Please, Bangladesh, the floor is yours.
Thank you, Honorable Chair, dear Excellencies and distinguished participants. Bangladesh is a densely populated country where 165 million people live in 148,000 square kilometer area. According to National Mental Health Survey 2018-19, 1 in 5 adults aged 18 years and above and 1 in 8 children are suffering from some sort of mental disorders, and there is considerable treatment gap for which we are seriously working to close the gap. To deliver the standard mental health services, we have shortage of mental health professionals, but government has undertaken necessary steps to increase the number of mental health professionals on urgent basis. We have a super specialized mental health hospital and 1 national mental health institute, which are giving services to the people with mental illness. Besides that, some other institutes like medical college and universities are having psychiatry department where people get services. Moreover, Ministry of Health and Family Welfare, under the leadership of our Prime Minister Sheikh Hasina, has undertaken an ambitious project to set up 8 more mental health hospitals in the country. In 500 sub-district hospitals of the country, there are non-communicable disease center corner where mental health support are provided along with other services. There are 14,000 clinics and 14,000 family welfare centers in Bangladesh, where also mental health services are being provided. By the direct intervention of our visionary leader, Prime Minister Sheikh Hasina, we have enacted the Mental Health Act 2018 and developed standalone mental health policy 2022 and National Mental Health Strategic Plan 2020-2030. We see rising mental health problems contributed by social conditions prevailing in the society, like natural calamities, climate change impacts, accidental trauma, excessive mental stress. In order to address these, we have taken community-based approach where people with mental health conditions are integrated in education, housing, vocational attainment, and social welfare services. Respected Chair, last 2 years during COVID pandemic, there is significant rise of mental health problems due to loss of near one, loss of job, livelihood, and increase the rate of early marriages among girls. Especially students were suffering from mental problems because of their confinement in their houses, as they cannot mix with friends and relatives and cannot have the education in their institutes. They have been using excessive electronic gadgets, which are also affecting their mental health condition. Time has come to take appropriate action to take care of mental health situation.
Please go to conclusion, please.
Developed mental health problem curriculum is being done, and web-based consultation is being done. Besides that, we want a better cooperation from our international partners to ensure mental health and psychosocial well-being of all people of Bangladesh. I hope a better world for the people with mental health problems. Thank you for your kind attention.
Thank you, distinguished delegate of Bangladesh. Now I give the floor to the distinguished delegate of Cyprus, followed by the distinguished delegate of Estonia. Please, Cyprus, you have the floor.
Honorable Chair, I would like to congratulate my dear friend Roberto Speranza for organizing this successful summit. Handling the COVID-19 pandemic was a priority for all health systems around the world, redirecting resources from the rest of the areas of health to the management of the pandemic. However, mental health was not only affected by the lack of resources. The lockdowns, the measures, the economic and social stress of the pandemic and the effects of the war in Ukraine have taken their toll on the mental health of quite a substantial percentage of the population. Acknowledging the fact that having high needs in mental health is not a temporary situation, we need strategic planning so as to build the necessary infrastructure to help people suffering from mental illness. We need to implement programs and services in the community for citizens, strengthening their mental health and to identify the vulnerable groups. We should orientate towards the prevention and early identification of mental disorders so that early intervention can avoid the chronicity of the disease with all its consequences. All the focus is on the patient and his individualized needs in the place where he lives and works, based on the biopsychosocial model. As for infrastructure for Cyprus, the fundamental objective of the mental health policy is to continue the psychiatric reform in transferring the services from the mental hospital to the community. Along this line, the mental health services of Cyprus implement progressively the decentralization and the upgrading of the services and programs offered within the community. Parallel to that, there is an ongoing effort to improve the quality of life of the patients in the mental hospitals. I strongly believe, as regards mental health, we are at a turning point and we need to act decisively and proactively in this area. People who cannot voice their needs are in dire need of help. Now, more than ever, there is a need to refocus both resources and attention on mental health. Thank you.
Thank you, distinguished delegate of Cyprus. Now I give the floor to the distinguished delegate of Estonia, followed by the distinguished delegate of Lithuania. Please, Estonia, the floor is yours.
Thank you, Mr. President. Dear colleagues, let me first join everybody in thanking the organizers for the inspiring summit. As was said by Rabbi El-Khamai in his keynote address yesterday, the most important factor for change is political leadership and policy development competences. In Estonia, it was only during COVID-19 pandemic that mental health issues emerged on the political agenda. Also, mental health challenges and need for comprehensive policies had been recognized by experts and workers long before. From the beginning of this year, a dedicated mental health policy department was established in the Ministry for strengthening policy development and coordination of implementation activities. Our first focus is on prevention and enabling community-level services and activities with special attention on youth. Of course, we go further with developing the care that we really had enough psychiatrists and other specialists to be on place where the situation is getting worse. However, we also need to look behind services provision and what we can do, create environments that support mental health in our everyday life, in schools and in working places. I really look on social partners to develop an environment which is calm, friendly, and really supports mental health of all workers and also employers at the workplaces. As Minister responsible for both health and labour, I am interested to promote mental health beyond the borders of health system. International events like the summit are important and a platform for sharing first-hand experience, both new knowledge as well as lived experiences and experiences of success, as well as policies and programs that did not work as they were intended. I thank again all the contributors and summit organizers from Italy for the interesting and inspiring days. Thank you very much.
Thank you, distinguished delegate of Estonia. And now I give the floor to the distinguished delegate of Lithuania, followed by the distinguished delegate of Nepal. Please, Lithuania, the floor is yours.
Excellencies, distinguished delegates, ladies and gentlemen, it's my honor to be here and discuss the key principles of policy and practice of ensuring positive impacts on people's mental health. Health in all policies is an established approach that seeks to systematically consider the health implications of public policies across sectors. Applying this approach to mental health is essential to remodel relevant social, educational, and economic policies. I truly appreciate and thank you, WHO, for its successful mental health advocacy and encourage all relevant international organizations to be key agents of this change in supporting policymakers. Building public awareness and interest is also a crucial factor to transform and scale mental health care. We admit that the main factor that stops people from seeking help is low-level mental health literacy, including a lack of knowledge, as well as prevailing beliefs that undermine the value placed on mental health. In Lithuania, we aim to increase mental health awareness by bringing together the needs and capacities of different sectors and promoting mental health in non-health settings through the National Mental Health Literacy Program. In order to change current practices towards right-based, recovery-oriented community services, we need to transform our behaviors and approaches to promote and protect mental health. We should empower people with lived experience by giving them voice in educating society, designing, assessing, delivering services, and encouraging peer support. In changing attitudes across the country, Lithuania is starting the implementation of national public campaign encouraging social contact between people with and without mental health problems. People with lived experience are also experts for WHO's Quality Rights Initiative and help us to strengthen the process of giving and receiving assistance to achieve long-term recovery. I strongly believe that these actions will improve public attitudes toward mental health issues, help us to reduce stigma and discrimination. Lastly, I would like to express my gratitude to the Ministry of Health of Italy for hosting this very important summit. Thank you.
Thank you, distinguished delegate of Lithuania. Now I give the floor to the distinguished delegate of Nepal, followed by the distinguished delegate of Palestine. Please, Nepal, the floor is yours.
Excellencies, distinguished delegates, ladies and gentlemen, Namaskar and greeting from Nepal, the land of Mount Everest and Gautam Buddha. Thank you so much for inviting us to this important summit. We are glad to share our experiences and learn from each other. Like other countries, mental health problem is a huge problem for Nepal. The first ever Nepal National Mental Health Survey of 2019-20 has shown the lifetime and current prevalence of mental disorders among adults to be 10% and 4.3% respectively, while 20 suicides happened daily last year. Realizing this, the government of Nepal has increased its political commitment to mental health services in recent years. A dedicated section for mental health has been set up and planning to set up a separate directorate for NCDs and mental health at the federal level. Constitution of Nepal has guaranteed health as a fundamental right, and Public Health Service Act has included mental health into basic health, thus making mental health service a fundamental right. We have developed National Mental Health Strategy and Action 2020 to guide mental health service planning and delivery, and a National Suicide Prevention Strategy and Action Plan is being drafted. Nepal government has already adopted integration of mental health into primary health care and implementing MHGAP intervention package based community mental health care package 2017 in 43 out of 77 districts and is being extended further. However, frequent transfer of the trained staff and lack of continuous engagement and follow-up has resulted in little systematic change. Similarly, a standard operating procedure for mental health is in operation since 2019, and a standard treatment protocol has been developed for mental health intervention as a part of basic health service package. National Suicide Prevention Helpline 1166 has also been started. Ministry also has programs to support treatment and rehabilitation of mental health patients in extreme poverty and homelessness and mental health needs of persons inmates. As part of the country mental health service package 2017, a range of training manual on in-service training have been developed and implemented which includes a total of 6 models and mental health curriculum, revision of preserving medical education training has been started. A total of 11 psychotropics has been included in free essential drug list. We have also integrated a set of indicators and data on mental health into the National Health Management Information System. Mental health and psychosocial support during COVID-19 pandemic. This ranges from development of a short-term MHPSS response framework for Nepal, development, translation, and adaptation of different technical tools and organizing trainings on psychological first aid, grief counseling, and stress management. WHO, especially initiatives for mental health, has been instrumental for the development of comprehensive mental health services in Nepal. And I would like to thank the WHO and government of Norway for their generous support to this initiative. In summary, we have clear vision about mental health services, including integrating mental health into primary care and other programs. There is also strong support from WHO and other UN agencies and NGOs. Challenges include a deep-rooted stigma and misconceptions about mental illness, lack of human and financial resources for mental health, and poor technical and managerial capacity of provincial and municipal governments to deliver mental health services. However, with our clear commitment and vision and support from international communities like you, we are confident to realize our dreams of providing quality mental health services as fundamental rights of our citizens. Thank you.
Thank you, distinguished delegate of Nepal. Now I give the floor to the distinguished delegate of Palestine, followed by the distinguished delegate of South Africa. Please, Palestine, the floor is yours.
Thank you very much. First, I would like to thank the organizers of this summit and the Italian government, and to acknowledge the support of the Italian cooperation to Palestine, and to bring to your attention our experience facing one of the world's most protracted political crises, with all of its challenges and opportunities, a military occupation that has resulted in the displacement of 2/3 and the detention on one-fifth of the Palestinian population. And this has resulted in the highest prevalence of mental illness in comparison to countries of the Eastern Mediterranean region. Meanwhile, we have been working relentlessly to reform our mental health system, implementing a mental health strategy, drafting a mental health act, devising a suicide prevention plan, and a child and adolescent mental health plan. Flattening the professional hierarchy of mental health services, engaging in constructive task shifting and task sharing, integrating mental health within primary health care and school programs, and establishing a mental health response to gender-based violence. We have at this time a well-developed network of community mental health services, and our hospital services are shrinking. And with an increasing public awareness of mental health during the pandemic, we are becoming very aware of the shortage of specialized mental health services, especially child and adolescent services and liaison units within general hospitals. Ladies and gentlemen, Palestine is poor in financial and professional resources, yet rich in experience and broad in vision. We understand that the liberation of the mind goes hand in hand with the liberation of the land. We realize that we still have a long way to go in our journey toward liberation, and that requires, when it comes to our field, the authenticization of mental health knowledge and the contextualization of evidence-based practices and interventions, and above all, the avoidance of pathologizing and medicalization of defiant human reactions to colonialism. Ladies and gentlemen, the damaging role of political power should not be ignored in mental health and psychosocial services. Thank you very much for listening. Thank you.
Thank you, distinguished delegates of Palestine. Now I give the floor to the distinguished delegate of South Africa, followed by the distinguished delegate of OECD. Please, South Africa, you have the floor.
Minister of Health of Italy and all those who supported him to organizing this successful 2022 Global Mental Health Summit, we congratulate you and thank you very much. To all the heads of delegations, ministers in attendance, good day. This summit is taking place 3 days after the commemoration of the World Mental Health Day on the 10th of October under the theme, Make Mental Health and Well-Being for All a Global Priority, very close to our theme this day, which is Skills, Rights and Care. These two themes complement each other well and are reminding us that making mental health and well-being a priority for all require us to strengthen skills, ensure human rights in mental health, improve the mental health care and treatment we provide, act now and learn lessons from the emergencies that we have experienced in the world, the main one being COVID-19 pandemic. South Africa has prioritized mental health as we align ourselves with the World Health Organization's dictum, which says there is no health without mental health. South Africa is gradually increasing resources that are allocated to mental health. The latest study has found that South Africa spends about 5% of its total public budget on mental health, which is higher than what actually is expected of 2.5 globally average. We, however, still need to improve our efficiencies to ensure that the resources allocated translate to good mental health outcomes. One of the areas we need to improve on is strengthening our primary mental health care and community-based mental health services. At the same study, as we other resources review, has found that our mental health services still largely follow a hospice-centric approach. We are putting in place a number of interventions to improve efficiencies in the way that we utilize available resources to ensure that our mental health services are accessible to those that need them and are of good quality. The current focus is mainly on infrastructure, including attaching mental health units to general hospitals, improving capacity of our healthcare workers through training and ensuring availability of psychotropic medication and evidence-based mental health care treatment and rehabilitation guidelines. As participants in this summit, I urge you all to strengthen collaboration with other sectors as well as civil society, including people with lived experience of mental illness, to ensure that we properly address the upstream determinants of mental health like poverty, inequality, education, many others that are mostly lie outside the mandate of the health sector. We can only win in reducing the incidence of mental illness if we work in collaboration with other sectors and civil society. Prevention is not only cost-effective, but is also ethical. We should endeavor to establish strengthening community-based mental health services, not only as a way of improving access to mental health services, but also as a way of reducing stigma. We should therefore be able to say we need to learn as much as we can from the COVID-19 experiences. Those experiences should take us forward in strengthening our collaboration and our interventions on the mental health processes. I thank you.
Thank you, distinguished delegate of South Africa. Now I give the floor to the distinguished delegate of OECD, followed by the distinguished delegate of UNICEF. Please, for OECD, you have the floor.
Thank you, Chair, and thank you, Italy. I think these meetings are going from strength to strength. I wish, of course, I could say the same about population mental health. We've gone from crisis to crisis, and the risks of poor mental health and well-being have gone up accordingly. You know the stats, but the OECD does stats, so I'm going to repeat them anyway. Students with mental distress are 35% more likely to have repeated a grade at school. People with poor mental health issues are 20% less likely to be in employment. 2/3 of people across OECD countries seeking mental health care report difficulties getting it, and of course people with mental health conditions tragically have much lower life expectancy. All these things add up. We at the OECD estimate that for OECD countries, poor mental health is costing us 4% of GDP, with 1/3 of this being due to lower employment and productivity. Yes, mental health is a right, but it's also an economic imperative. There are 2 lessons I'm going to talk about, neither of them new, but we have to keep repeating them until we learn the lessons. The first, as we've all agreed, mental health is a social issue, employment issue, education, legal system, whole of society issue, and a whole of society issue demands a whole of society response. I might say that other sectors probably got this earlier than the health sector realised. 5 years ago, I was fond of saying it was far easier to get employment ministers to talk about mental health than health ministers. Maybe that's less so now. I think we called for these sorts of cross-sectoral actions in our 2017 Council recommendation on integrated mental health skills and work policy. We recently reviewed progress in OECD countries since then. Good progress in schools, okay progress in employment, virtually no progress in social policy in integrating mental health. Second lesson is health systems still do not give mental health the priority it deserves, remains under-resourced in a way that would be unacceptable in the rest of the health sector. Indeed, the share of mental health spending as a percentage of total spending in OECD countries is constant over the past decade, despite all the attention we've given it. We shouldn't just wring our hands about this. We should address why. I agree strongly with what the Canadian ministers said earlier this morning in pointing at data gaps as being one of the things that's missing, particularly in the community sector, particularly to reflect lived experience in a systematic way. I look forward to making progress on these issues before the next summit. Thank you.
Thank you, distinguished delegate of the OECD. And now I give the floor to the distinguished guest of UNICEF. Please, UNICEF, the floor is yours.
Thank you, Chair. Excellencies, partners, and colleagues. We are grateful to Minister Speranza and the government of Italy for hosting this year's Global Mental Health Summit and their ongoing commitment to mental health. Mental health is important at every stage of life, from childhood and adolescence through to adulthood. Sadly, for much too long, the mental health and well-being of children and adolescents has been one of the most neglected and least funded fields. Many governments still spend only a few cents per capita directly on mental health, and allocations from official development assistance are inadequate. As part of the State of the World's Children Report on Mental Health, we conducted a series of discussions with young people to help us better understand how they perceive and experience mental health around the world. We heard adolescents talk about feelings of sadness, loneliness, shame, boredom, anger, hopelessness, defeat, pressure, and stress. They described experiences of depression and anxiety, which many noted going at lengths to mask. We heard about the stigma that deters them from seeking support when they need it and turning to harmful coping strategies as a way to deal with distress on their own. We heard that all of this was only heightened with the onset of the COVID-19 pandemic. A year later, we find ourselves trying to move beyond the pandemic and pushing to restore basic services. But we can and must ensure that we build back better and that young people have access to affordable, confidential, and responsive mental health and psychosocial services by investing in capacity and approaches for child and adolescent mental health across health, education, child protection, justice, and other areas of work, with emphasis on solutions spearheaded by young people themselves. In the context of this year's Global Summit theme, Skills, Rights, Care, we call on member states to universally support children, adolescents, and their caregivers to strengthen their ability to manage and navigate transitions and challenge and seek help when they need it. Throughout the summit, we have highlighted 3 key points. One, that acting early to support healthy attachment between children and their caregivers and ensure safe school and community environments is the best investment governments can make to promote good mental health, prevent poor mental health, and respond to complex mental health issues facing our children today. Second, cross-sectoral MHPSS financing from governments is essential to ensuring the mental health of our young people and building up future generations. And third, supporting families and schools as the primary source of support and security through community-based MHPSS is critical in order to improve access and improve mental health. Restricting our delivery and entry points to one sector risks losing access to the most vulnerable populations in need of mental health. Governments need to ensure cross-sectoral cooperation and financing, and a competent workforce is trained to support children, adolescents, and their caregivers, and that quality evidence-based mental health and psychosocial approaches are implemented across prevention, promotion, and treatment continuum. And UNICEF is doing its part, uniting with our partner WHO through our joint program on mental health to accelerate action at country level. Earlier this week on World Mental Health Day, we launched 2 new global resources to enhance the evidence base around child and adolescent mental health interventions and fill the data gap to advance policies and services that respond to needs of young people. Thank you, Mr. Chair.
Thank you, distinguished delegate of UNICEF. And with this last intervention, we concluded also the second round. I would like to thank all heads of delegations for their reaching and constructive contributions. And before closing, let me thank Mr. Speranza. He's at the end of his mandate as Minister of Health, and I think that no better conclusion of his mandate might have been this Global Mental Health Summit. So thank you, Mr. Speranza. I declare closed this session.
Ladies and gentlemen, the closing session is going to start. Please welcome Mr. Davide La Cecilia, Diplomatic Advisor to the Minister of Health, Italy.
Ladies and gentlemen, it's really a pleasure for me to introduce this last session of the Global Mental Health Summit focused on the Chair's report and the way forward, and thank all the participants, the many delegations from all over the world which contributed to the debate, the experts, which enriched the different sessions, and the organization of the civil society, which made our interaction very lively. Of the many ideas which emerged from these 2 days, I want to pick up the one that established a very strong connection with the current events, which are having a deep impact on our life and mental health. These are challenging times. The global community has been fighting for almost 3 years a catastrophic pandemic, affecting the lives of each and every one of us. The virus has caused the deaths of millions of people, severely impacted the economic, hampered the progress towards the achievement of sustainable development goals. At the same time, as the intervention of the First Lady of Ukraine reminded us, we are now facing the reality of an unprecedented conflict in Europe, which has caused thousands of victims and millions of refugees, and brought anxiety and uncertainty in our societies. Most vulnerable people and most marginal groups and societies are the most affected by these events, as we affirmed in our G20 conclusions 1 year ago. And one of the recommendations of the G20 under the Italian presidency was to strengthen mental health as a crucial element of recovery. Mental health, that was the key message, must be part of the transformative change which will allow us to build back better after the COVID. And I'm very glad that this idea has been widely reflected in this meeting. I also like to think that this conference is part of a process. It is not by chance that it is called global, and it is consolidated its role as a forum where the international community, experts, and the civil society will reflect on mental issues, on mental health issues in the future. The hope is that it will grow as a permanent platform, meeting on a regular basis. With this toast, I leave the floor to Professor Fabrizio Starace, National Health Council, for the chair report of the Global Health Mental Summit 2022. The floor is yours.
Thank you, Ambassador La Cecilia. We are approaching the end of this wonderful fourth Global Mental Health Summit, a real occasion for sharing experiences and competencies and creating a renewed professional and political network aiming to improve and support well-being and social justice. Before going ahead by reading the chair report of this summit, let me acknowledge the technical and scientific work done by my colleagues, Dr. Calamandrei and Dr. Picardi from the National Institute of Health, and Dr. De Santis from the Ministry of Health. The Global Mental Health Summit held in Rome on October 13-14 proceeded along the roadmap launched in London in 2018 by further increasing mental health awareness and commitment among policymakers and the civil society. During the event, attended by more than 50 countries and international organization delegations, a number of critical topics have been debated, all grounded in an overarching framework emphasizing the human rights and dignity of people affected by mental disorders, the valuable contribution they can give for designing policy, law, and services, and the central role of a community-focused approach to mental health. Mental well-being is deeply impacted by social determinants of health. Therefore, promoting mental health through activities and interventions performed in the community rather than in large institutional settings is based on the evidence that communities will best establish the mental health facilities that fit their unique needs and that care is best provided where people get on with their lives. The fundamental principles of community-based mental health include proximity, responsiveness, stakeholders' involvement, and a holistic, person-centered, right-based approach. The development of community-based mental health includes, among others, moving away from large institutions, overcoming old hospital-centered systems, shifting to a resourceful and fully enabled mental health service network, integrating mental health care into social and welfare systems. Pursuing these objectives requires a multi-sectoral, whole-of-society approach, including health, education, research, welfare, housing, and labor market. Key actors are primary care physicians, teachers, social workers, mental health professionals, families, and people with lived experience. However, the implementation and sustainability of community mental health care purports also a change of mindset. First, by recognizing and increasing human rights of people who are suffering from mental illness. People with mental health conditions continue to be subject to widespread human rights violations due to stigma and discrimination. It's time to reverse course by recognizing people with living experience leadership, involving patients in shared decision-making, limiting forced treatment, including physical constraint, and decriminalizing suicide. To reduce stigma, national programs driven by the social contact theory and co-produced, co-led by persons with lived experience are strongly recommended. Secondly, a plan of investment is essential to reallocate resources and to assure adequate mental care funding consistent with physical health, to address the social determinants of health, to promote equity and emancipation, to increase the social capital of communities and individuals, to include productive investments that have potential to transform people's lives and community services themselves. The pandemic offered us an extraordinary opportunity to rethink the ways to take care and support people with psychological distress or mental illness, and highlighted the need to include mental and psychological issues in efforts towards preparedness to emergencies, including training at local, national, and global level. The ability to provide and scale up mental health and psychosocial support goes beyond the health sector alone and needs a coordinated approach across a number of sectors and actors. A vast amount of tool and expertise is available for a widespread and effective use, according to the BBB, Building Better Before principle. Given the pandemic-related substantial increase in work-related stress, there is a crucial need to promote workers' mental well-being and alleviate stress by implementing appropriate workplace interventions and reducing stigma related to mental ill health. Addressing this topic during the training of human resources, management, and other professionals would help raise awareness and lead to the implementation of good practices. The promotion of mental health at work requires a multi-level strategy due to different typologies of risk exposure. Workers' mental health needs to be pursued by promoting healthy workplaces and enacting structural and organizational measures. In addition, individual interventions should be provided for health, volunteering, humanitarian and emergency workers, as their work environment is difficult to improve in the short term and they are exposed to multiple sources of burden. A skilled, capable, and motivated workforce is vital for any mental health system to operate effectively. However, human resources for mental health remain insufficient and inequitably distributed to meet population needs. While the predominant focus of workforce development in most countries is on specialized clinical care providers, Non-specialist care providers may play an important role in promoting mental health through scalable interventions, particularly in contexts with scarce financial resources or difficult in recruiting healthcare personnel. In planning for workforce development and associated capacity building, it should be ensured that they are based on the expected needs of the population, cover not only specialist care providers, and enable and empower different occupational categories. In fact, the human resources for mental health cover a range of needs, disciplines, professions, such as health professionals, social and community workers, teachers, police officers, researchers, government officials, policymakers. Important skills need to be developed, such as psychosocial support skills, non-clinical capabilities related to leadership, management, teamwork, and skills related to self-care, recovery, rights, citizenship. A multi-sectoral approach, again, including service user and person with lived experience in capacity building and workforce training, should be implemented, making larger use of digital and e-based available resources. There is evidence that digital interventions work in the field of mental health. On one hand, technology can help mental health professionals to get better what they are doing now. On the other hand, new ways can be developed to deliver therapeutic interventions that are known to work in order to improve access, uptake, and resilience of services. Moreover, new interventions can be developed based on the possibilities of new technologies. Communities can build and benefit from digital interventions of different intensity and sophistication, from unguided self-administered interventions to web-based psychotherapy, depending on their resources. Although the current massive increase in smartphone use provides the opportunity to reach a very large number of people and possibly to collect useful information to monitor their mental health, it raises serious questions about privacy and risks of misuse and mistreatment. Again, involving persons with lived experience in designing, planning, and co-producing new digital interventions, bearing always in mind that obligation to individuals' right protection is an important element in developing these innovations. Children and adolescents, due to their high exposure to adverse experiences, continue to bear the brunt of the mental health burden globally. Even in countries with well-established healthcare systems, most children and adolescents with mental health and psychosocial difficulties do not receive the support they need. A whole-of-society approach is required to improve the environments for children, caregivers, by integrating promotion, for example, emotional education, and protection of child development and mental health, meeting children where they live, supporting skills development of children and carers, and monitoring quality of care. To this purpose, a quality, right-based, and multi-sectoral system of care is instrumental, as well as children and adolescents' active involvement in the process of designing dedicated services. Finally, migrants, asylum seekers, refugees, they are exposed to several stressors for mental well-being, and barriers to access adequate mental health care may be present throughout the migration cycle. Regrettably, there is often a shortage of trained cultural health mediators and culturally competent health workers. Also, even when mental health services do exist, and migrants, asylum seekers, and refugees have the right to access them, underutilization of services is often observed, mainly due to language and cultural barriers. Attention must be paid to cultural diversities and to create competencies among migrants' communities. Adopting proactive initiatives to outreach them on the ground is therefore crucial to ensure they can routinely access mental health services at all stages of the migration process: pre-departure, transit, arrival, and in some cases return. Continuity of care plans should be granted both as a protection of their human rights and a prerequisite for their full integration into communities. On these premises, all countries and international agencies convened in Rome for the Global Mental Health Summit urge all relevant actors to implement recommendations presented in the WHO updated Comprehensive Mental Health Action Plan 2013-2030 and to improve integrated mental health measures in all stages of life. Countries and international organizations participating in the Rome Global Mental Health Summit renew their commitment to monitoring and documenting progress made to advance community-focused approach to mental health, also in the context of the forthcoming annual Mental Health Summit. Thank you very much indeed.
Thank you. Thank you very much, Professor Fabrizio Starace. And now I would like to give the floor to Dr. Sergio Iavicoli, Director General for Communication and International Affairs at the Italian Ministry of Health, for the highlights on the Global Mental Health Summit 2022. You have the floor.
Thank you. I think the best way to introduce some reflection on highlights of this summit before also making the acknowledgements to the organization, I think is to have a brief video that we prepare with some highlights, including the last session. So please go with the video. I think when it comes to acknowledgement, it's always difficult because it's very difficult to recognize and to remind all those contributed. I think it was really beside our co-worker, our teams that work, it was a very participated work on a global base and international. I think there is a strong link with the previous edition, and the sharing of good practice of the previous organizers was very useful and very active in the steering committee. So first of all, of course, I want to thank Deborah for being, Deborah Kesten and all the Department of Mental Health of WHO for being the engine of this network and really steering up. But also who initiated, so the words of wisdom of Tim Kendall has been always very useful and very important in the development of the program. I think sharing, and I think it's also what we share with Fabrizio, then we work together in organizing this. And also René van der Waals and Frank Bellivier, who was the other previous key people in the organization of the previous summits, and all the other people of the steering committee. And of course the backbone are all the speakers, coordinators of thematic session on panels. They made a huge work in building up all together, and all the speakers. And particularly let me thank the people with lived experience that brought an important added contributions and food for thoughts for the delegations. And of course, in addition on the scientists that were reminded by Fabrizio that supported the development of the program and the core documents and the development of the concept note and then the output. I want also to thank the scientific secretariat, and let me particularly thank a young medical officer that supported and coordinated with me this, Guido Marenghini, and all the other co-worker, Gebre Medin, Gebre here. I'm very difficult to name. We call Gebre, and it's our, key person for a long time in international organization, and also Lucio Lemme for following this, and the other co-worker, so also Barbara Porretta, and that work with the whole office and the managing of our directorate, so Alfredo Dari and Giorgia Gabrielli, Massimo Aquili, and Marco also, and Spizzichino, and also Dr. Pasquale Bisceglie. So all this group and this team, has been a very passionate and stimulate together with the group and the other team. But I think also beside everything, I want to thank more than 150 people. They are technicians, they are people from the organization, from all the services, the cameramen, and all the other people that behind the scene make it this possible. And a very special thanks also to the interpreters, and particularly the hands and sign interpreters, that we want to thank them. They made a huge work in organizing and assuring the translation, and also the interpreters that translate into Italian, French, English, also on the platform. We have 1,000 people around the clock all around the world following the summit. And also a very special thank to our hosts, this fantastic venue, so the historical hospital of Santo Spirito in Sassia and all their management team. But beside offering a fantastic venue, they were also assuring, for instance, all the medical and plan and support. And Santo Spirito in Sassia is, in this area, is offering to the community of Rome services, medical services for 800 years. And they're still active, so back to the historical part, there's still an hospital that's working every day. I want also to thank also the security that was offered by all the police officers that you saw around that assured the security of the system in the Ministry of Interior and all the other institutions, and particularly also the Ministry of Foreign Affairs and International Cooperation has been part of the organization. So with this, I definitely forgot somebody, so I apologize already for this, but thank you all, and has been a very stimulating experience.
Thank you very much, Dr. Sergio Iavicoli. And now I am pleased to call onto the stage Honorable Roberto Speranza, Minister of Health of Italy.
Yeah, thank you very much, dear colleagues, excellencies, ladies and gentlemen. I'm really grateful to all of you who have attended in person, coming from every part of the world, and people connected via live stream at the work of the 4th Global Mental Health Summit. And thank you very much for your active participation during the past 2 days. Obviously, a special thanks goes to the coordinators, moderators, and speakers whose valid and constructive contribution to this 4th Global Mental Health Summit has led to concrete steps forward. I would like also to express my deepest gratitude to all the ministers here. My colleagues, thank you very much for being here and for everything you have been doing in these 3 years together. Before the conclusions, I want to give you a very important announcement. I would like to let you know that the next meeting, the next Global Summit, the 5th Global Summit, will be held in Argentina in a spirit of continuity and consistency with the work carried out together on mental health. Minister Carla Bizzotti, my friend Carla, will speak after me at the closing session, and I would like to thank her for having accepted to take the baton from Italy as we took it 1 year ago from France, thus creating a solid bridge of continuity in our shared and common values. The outcome of these 2 days, I think, is very important. And personally, I am really confident that this outcome will help us in the future of building and improving all actions together, plans and strategies on mental health at global, regional, national and local levels. During the discussion, it has been clearly said that mental health is not only about health. Mental health is not only about health. Mental health is also about social justice, inclusion, and is about respect for human rights, and individual dignity. No one has to be left alone, and persons affected by mental health conditions must be able to exercise their full range for human rights and to assess high-quality, culturally appropriated health and social care in order to promote recovery, attaining the highest possible level of health, and to fully participate in society at work, free from stigmatization and discrimination. WHO has highlighted the global context of mental health in the WHO Comprehensive Mental Health Action Plan 2013-2030, and in particular in the World Mental Health Report, Transforming Mental Health for All. WHO highlights why and where change is most needed and how it can best be achieved, based on the latest evidence available, displaying examples of good practice from around the world and voicing people's lived experience. We acknowledge that the important results that we had achieved up to now in policies, plans and action on mental health are also due to the hard work and the important role played altogether by institutions, civil society, scientific communities, physicians, psychologists, psychiatrists, nurses, health and social care workers, and all the other professionals involved and people living with mental health and their families and the involved international organizations. So we need to continue this also for the future. I wish to express my deep and sincere appreciation to all those who have worked every day since months ago to organize this event here in Roma, making it a great success. Thank you, Davide. Thank you, Sergio. Thank you, Giovanni, Sandra. Thank you, Fabrizio, and every one of us who has been working on this very important event. Thank you for the collaboration of all, everyone. And now, of course, is the time to tell us arrivederci, goodbye. But before, let me with great pleasure pass in the hands of my dear friend Carla Bizzotti, the Minister of Health of Argentina, the responsibility of the organizing of the 5th Global Mental Health Summit. I want to say to Carla, to close my speech, only two things, because I think that we worked together a lot in these difficult years. We have been very united. Sometimes our countries are divided, but the problems we face every day gives us the chance to be very united. And I think that we have two great lessons coming from the pandemic days. The first lesson is that health cannot be considered a national issue. For too many years, health has been considered in every part of the world a national or a local problem. Health is not a national problem, is not a national issue. It's a great international issue. That's why we have to work together. As you know, Italy has been one of the first countries hit by COVID, out of China, of course. And when I started this job, there were ministers from all around the world calling us and saying, how is it working? And after weeks by weeks and months by months, we all realized that the world is very united. And the problem I had in Roma was the same problem coming in Buenos Aires or in Japan or in South Africa, in every corner of the world. So I think we have to know that health is a great international issue and a great international challenge for everyone. And the last thing I want to say is that now we have a kind of window of opportunity, Carla. Could be considered strange or a kind of paradox, but my personal opinion is that this is the moment in which we have a window of opportunities, because people all around the world, in every country in the world, now knows better that if you put money on health, you are not only in a cost policy, but you are making the greatest investment on the quality of life of people. Personally, I don't know for how much time this window will be open, but now we have an open window. So this is the time to challenge, this is the time for more investment, this is the time to try to change. And I think that this is our aim, and at the end, this was the purpose of this meeting. This was why I asked to my French friend minister, Olivier Véran, 1 year ago, to have this meeting today here in Roma. And I'm sure that this meeting gives a message of hope to every corner of the world, that we want to make a stronger policy at the international level on health. And together, I'm sure, we will win this challenge. Thank you very much, and I give the floor to Carla.
Muchas gracias. Grazie mille. Well,
Thank you so much.
Thank you for being so humble, so generous, for your interest on the common good, for sharing your experiences, your lessons learned during for sure, the major crisis, humanitarian crisis that we experienced in the world in the last century. We share some lessons in the G20, and we keep in touch, and now being here, giving me this responsibility. You really, really have done a lot. You did it well, and I wish you the best. Thank you very much. Yeah. So I continue formally. Good morning, dear ministers and delegates. Firstly, I would like again to congratulate the Minister of Health of Italy and all the Italian team and the World Health Organization for the amazing organization of the summit, and also for kindly inviting me to participate. I have attended several thematics workshops which have been really interesting and engaging, and also a few bilateral meetings which were very interesting and inspiring. Particularly, it has been a true pleasure to share the workshop on implementation and sustainability by honorable women colleagues from Canada, Australia, and UK. And I also thank Dr. Deborah Kestel, Director of Mental Health and Substance Use Department at the World Health Organization, and her team for her continuous support and collaboration in this relevant issue for my country. Argentina agrees on the importance of emphasizing the protection and promotion of rights in order to ensure quality of mental health and psychosocial care to individuals with mental health conditions and caregivers. And in this sense, we have a series of regulations aimed to protecting the mental health of all people and respecting the human rights of those with mental health conditions. In the face of the alarming increase in these public health problems due to the impact of the pandemic, the war, and many other issues in the world, Argentina initiated a cross-cutting, intersectorial, and community approach that not only reinforced coordination mechanisms of mental health and psychosocial support in emergencies, but also promote training and update and design protocols, in addition to specific care plans for primary health care force, but also incorporate for the first time medication for mental health care in the kids for the Remediar strategy, which is a strategy for the national state in order to guarantee the universal access for essential medicines in primary health care centers. In this context, Argentina's president himself led the launch of the federal strategy for comprehensive approach to mental health as substance use, with a human right perspective and respect for gender and diversity. It is a challenge that involves transversal, intersectorial, and community work, and of course, 100% of increase of budget. Our president, Alberto Fernandez, has defined mental health as a substance use as a priority issue in public health, convinced that there is not health without mental health, and there is not mental health without social justice, human rights, and gender-based approach to leave no one behind. A sign of Argentina's commitment and for express request for the President, it is an honor and a pride for me personally and for my country, as Roberto announced, to share with you that Argentina will host the 5th World Mental Health Summit in 2023, which will be held in Buenos Aires on a date to be confirmed. This is an important opportunity not only for Argentina, but also for Latin America to share the huge work regarding this relevant challenge. Looking forward to meeting you in Buenos Aires soon. Thank you very much.
Qualcosa, finisce una musica. C'è una musica?
you.